Hi, this is a recording of the Chapter 37 lecture, Nursing Care of Patients with Disorders of the Urinary System. This is supposed to build off of Chapter 36, and it's a long chapter, so I'm going to try and go a little bit faster just so I can get through the materials because there's just a lot to cover with this chapter. These are the learning outcomes. Again, if you're not circling back after reading the chapter at least one, you are missing out on some of the things you should be able to take away from this chapter. So make sure you circle back and look at those after you're done reading the chapter. But with the urinary disorders, of course, we have to start with UTIs, in which there's an invasion of the urinary tract by bacteria. The urinary tract is sterile beyond the urethra, and UTIs are the most common hospital-acquired infections, which ascends from the external urinary meatus and is mostly caused by a bacteria called E. coli. So here's how it kind of works. You have your kidneys and ureter, your other kidney and the ureter, and then you have the bladder, and then I'm going to make the urethra a little bit bigger, but this is your urethra is basically a tube that allows the urine to drain out of the bladder into the outside of the body. Your urethra opens into the perineum, which, as you know, is full of normal flora. Normal flora is fine if they stay where they're supposed to be, but normal flora is constantly trying to multiply, and they love to be in parts of your body where it's dark, warm, and moist, because that means that there's more nutrients and resources for these bacteria to grow. So they actually will try and enter into your urinary opening of your urethra, and they will try to climb up your urethra. The way that your body keeps you safe is that every time you urinate, you're actually flushing out some of this bacteria through urination. And so being able to urinate through your urethra is actually protective of the urethra because you're constantly flushing out this bacteria. That's why you need to be able to go a certain number of times a day in order to keep your urethra healthy and low on bacteria. So given that, UTI risk factors are when you have incomplete bladder emptying as well as urinary stasis, because when you have your kidneys and your bladder and your urethra, the urine that's inside of your body is sterile. So that means that there's no pathogens in it. Normal flora loves to be in parts of your body where it's sterile because there's a lot of free space. And so they try to multiply to take over those free spaces. So you have normal flora that's traveling up your urethra. And if they reach your bladder and there's a lot of urine that's just sitting in there, bacteria loves that because it likes to, it will actually consume the waste products that are in your urine as a source of nutrients. And so the bacteria is really going to multiply if they can get into your bladder and get access to a bunch of sterile urine that carries a lot of what's waste for you, but what is actually nutrient resources for these pathogens. And so incomplete bladder emptying, urinary retention, or urinary stasis are all risk factors that can increase the chances of developing a UTI because you're basically leaving nutrients out in the open for these pathogens. Contamination, the perineal and urethra area refers to maybe somebody who doesn't have access to clean water in order to wash frequently or daily in order to keep the amount of normal flora in the perineum low. So somebody who's maybe not showering frequently or doesn't have access to clean water, they're going to have a lot more normal flora in their perineum, which then means that they're constantly trying to go up the urethra and therefore can cause increased incidences of UTI. Instrumentation refers to if they maybe recently had surgery or had insertion of a urinary catheter. A urinary catheter is always going to be it's always going to increase the risk of UTIs. Reflux from faulty valves, you have what's called sphincters at the base of the bladder, which allows the bladder to open into the urethra in order to let pee out. And so if there's something wrong with these valves, these sphincters, then either they could be not opening enough in order to allow urine to come out, in which case then you're going to end up with urinary retention, or these valves are opening all the time. And so then that means that it gives the normal flora more opportunities to climb up the urethra and get into the bladder and have access to urine. If you have previous UTIs, especially if the UTI reached the bladder where the urine sits, a lot of times that's an issue because even if your body was able to flush out some of this pathogen, a lot of times it's not going to be a complete flush because we know that bacteria can get very good at anchoring down on in your body somewhere. They like to really hide in the nooks and cranny, and unless you were able to really scrub, like you when you're washing your hands, the scrubbing motion actually scrubs bacteria off of the surface of your skin. You can't do that with your bladder. And so therefore, it's very easy for a couple of pathogens to hide in the nooks and crannies of the bladder and then wait until the bladder has been flushed out in order to remultiply again. So if you previously had UTIs and it was really severe and it got into your bladder, a lot of them will try to hide in the bladder in order to come back at a later time. Female anatomy, women's urethra are much shorter compared to men's. On average, the woman's urethra is maybe an inch or two. On average, men's urethra can be as long as 8 inches or sometimes potentially longer or shorter, depending on the person. But there's more of a distance to travel for the pathogen to get into the bladder. And so females, unfortunately, because our urethras are shorter, it's a shorter distance for the pathogens to travel. Whereas the males' urethra is much longer and therefore more of a distance to travel. And they're more likely to be flushed out before they can reach anywhere very far. Aging changes, we previously talked about how immunosenescence in the elderly makes them more susceptible to infections. And then related to the aging changes are also changes to the urinary system. We don't produce as much urine, we can't hold as much of it, and we may be more likely to retain urine, which are all risk factors for UTIs in general. And then genital piercings, because of how close our genitalia and our urethra opening are, when you have a genital piercing, you actually give normal flora another reservoir to hide it. Chapter 8, we learned about the chains of infection and how reservoir is a hiding spot for pathogens. So this genital piercing becomes a hiding spot for normal flora, and so they're going to thrive more when the person has a genital piercing, which then makes it harder for the perineum to stay fully clean. Some of the signs and symptoms of UTI will be urgency, which means that they have to go very urgently. They cannot wait and they cannot hold it for 5 minutes. They have to go right now. Frequency means that they're peeing more than more than 6 times a day, because the average person pees about 6 times in a day. And so that could be like every other hour while awake. And so if they're peeing more frequently than that, that could be a sign that they have a UTI that's developing. They could have a burning sensation. The reason for that is because when you have a UTI, you have the signs and symptoms of infection, which are um, redness, pain, swelling, and increased temperature. Now, all of these 4 signs and symptoms of inflammation, obviously the urethra is going to have swelling, pain, and increased temperature, meaning warmth. On top of that, not only is the urethra itself inflamed, the pee that's inside of your body will also be about body temperature, which for most people, our body temperature is anywhere between 96 to 99 degrees Fahrenheit. And so you're letting a really warm liquid out of a part of your body that is already has increased warmth due to the presence of an infection. The increased warmth with the warm liquid flushing over it is going to make that part of your body feel like it's on fire because it's very hot. It's going to feel like it's very hot. And so the burning sensation is actually related to the increased temperature of your urethra due to the presence of an infection. Then you're going to have cloudy urine. The cloudiness is because, as you know, with infections, you have the signs and symptoms of inflammation plus the presence of pus. Now, if that pus is being formed inside of your body in the urinary tract, that pus is eventually going to mix in with urine and then also get carried out of the body. So the cloudiness of the urine is actually due to the presence of pus drainage. Foul smelling urine. Last chapter, I talked about how normal urine smells like ammonia because ammonia is nitrogen based. So you're really smelling the nitrogen of when you smell urine. If it smells like farts or if it smells like bowel movements when somebody is going peeing and urinating, it actually means that there's bacteria in it. As you remember, the normal flora in your GI tract will produce methane gas as part of their cellular function. The methane gas makes up your farts. When you smell farts, you're actually smelling methane gas produced by your gut bacteria. So if your urine smells like farts, it means that there's bacteria in your urine and they're producing methane. That's why you're going to smell a foul smelling urine when somebody has a UTI. Hematuria is blood in the urine, which is certainly possible when you have inflammation. Some of these blood vessels that are inflamed could break, and therefore red blood cells could leak out. And then pelvic pain is because the bladder is in the pelvis. And so if the bladder is inflamed from the UTI, it's going to cause pain in the pelvic area. In older adults, you actually will see some of these signs and symptoms less, but you'll see more of fatigue, confusion, and delirium. The reason for that is because when you are an older adult, you have immunosenescence. And so, although your white blood cells may be still active, your body may not be producing a fever in order to kill off some of these pathogens, just because your body slows down. And this is a normal age related change. For the older adult, we won't see the typical signs of your UTIs, but we will start to notice that they can become more fatigued, and that's because their body is supporting their immune system in order to fight off this infection. So they're using up all their resources already. The confusion comes from the fact that when you have a UTI, your body's not as able, especially your kidneys, are not as able to filter out some of your waste products. And we talked about how these waste products are nitrogen based. Ammonia, which is nitrogen based, is a waste product that usually ends up in urine. But if you have a UTI and your body can't filter the ammonia out of the system, the ammonia will remain in your circulatory system and then gets deposited in different organs. Ammonia is one of the few waste products that can cross the blood-brain barrier, meaning that ammonia can potentially be deposited in the brain. No other waste products can usually do that. So ammonia ending up in the brain will impair brain function and therefore cause delirious symptoms or symptoms of confusion. And so, generally speaking, the way we're gonna, be able to tell is if the patient is normally alert and oriented times 4, but suddenly they're only alert and oriented times 2. A lot of times that could be the first sign of UTI in an older adult. Cystitis is the inflammation of the bladder. And so you're going to see the urgency, frequency, burning, cloudy, foul-smelling urine, hematuria, and pelvic pain, plus pressure in the pelvis area. And that's because the bladder is inflamed, it's swollen. And so that swelling in the bladder can feel like pressure in your abdomen. In pyelonephritis, pyelo, remember, meaning renal pelvis, which is the big funnel that connects the kidneys directly into the ureters. In pyelonephritis, the UTI has traveled into the kidney itself. And so you're going to see the urgency, frequency, burning, cloudy, foul-smelling urine, hematuria, and pelvic pain, plus coastal vertebral tenderness, high fever, chills, nausea, and vomiting. The high fever, chills, nausea, and vomiting are now systemic symptoms of UTI. And the reason for that is because when the UTI, the infection, has reached the kidneys are a highly vascularized organ, which means that it has access to a lot of blood supply. So when the infection has reached the infection can now get into the bloodstream and then circulate into the rest of your body. This generally will cause, is the first step of something called urosepsis. And so with urosepsis, we'll kind of talk about that in just a second. But first, this is a picture of a costovertebral angle pain. The costovertebral angle is created by the spine in the middle and then by the 12th rib, which sits at an angle to the spine. So if the patient reports costovertebral pain, that's generally because that infection has now reached the kidney itself. Oh, and then somebody in my class pointed out, oh, is the right kidney supposed to sit lower than the left? And actually, yes. This is not an uneven image. This is actually more anatomically correct than you might imagine. And the reason for that is because on the right side, you have a large organ known as the liver that sits directly on top of the kidneys. And so therefore, the right kidney is going to be slightly lower due to the presence of the liver. Now, the different types of UTIs are urethritis, in which there's inflammation due to infection, irritant, trauma of the urethra. Now, besides infection and trauma, the irritant that could be traumatizing to the urethra are things like a bubble bath, such as a bath bomb or bath salts. These are chemicals that the urethra normally would not be exposed to. And so these could certainly cause irritation of the urethra. And also, a lot of people tend to take baths wrong. So the average person thinks that you can take a bath by filling the tub with hot water, getting completely naked, and then going in to sit in this tub of water. What will actually happen is that this water is never hot enough to actually kill the normal flora on your body. This water is then acting as a way for normal flora in your body to float out and leave your skin and then to sit in this pool. You've often heard that taking a bath is similar to sitting in a pool of your own filth. That's what people mean. You're sitting in a tub full of your own normal flora, which now this normal flora can float anywhere. This may have been just normal flora that's on my chest, but because I'm now in the water, it's now part of the water. And then it gives the normal flora from my chest an opportunity to go down to my perineum and then potentially crawl up into the urethra and cause me to have a UTI. And so that would be how that functions. So the proper way to take a bath is actually to take a shower first and to wash yourself off with some soap and rinse off and then step into the tub because you want to remove as much of those pathogens as possible from your body first before you sit in a pool of your own filth. But ideally, at that point, you're not filthy anymore. So it's not a pool of your own filth. It's now just a pool that you can sit in and enjoy. I've had students ask me, well, can't you take a bath first and then take a shower? Well, absolutely you can, because ultimately at the end of the day, we just want to make sure that these pathogens are not staying on your body or getting access to a part of the body where it's not supposed to be. However, I personally think it makes more sense to shower first before I sit in a bath because I can sit in a bath for like 30 minutes. But if I'm sitting in the bath for 30 minutes before I step into my shower, who knows what my normal flora on my body that's in this pool now is doing in those 30 minutes. All right, cystitis is the inflammation due to infection of the bladder wall. It's usually caused by E. coli and can be from catheter use or chemical irritants, medication, and radiation therapy, which I'll talk about in a later slide. Then pyelonephritis is an infection of the kidneys. We talked about how that would be the UTI traveling up the urethra, into the bladder, into the ureters, and then into the kidneys. And that's really bad because then that infection now has access to blood supply and can circulate to any other parts of your body, leading to something known as urosepsis, meaning sepsis caused by a UTI. There are other things that can cause a sepsis, as you learn from chapter 9. And so with urosepsis, it is specifically sepsis caused by UTI. It's a very serious complication because you know that sepsis is the first step to developing septic shock. And unfortunately, it is very common in older adults because older adults don't have your more common signs and symptoms of UTI, such as urgency, frequency, cloudy, foul-smelling urine, et cetera, et cetera. The nursing data collection that we would do for a patient with UTI is to make sure to see if they have any predisposing factors such as catheter, recent urinary instrumentation, or surgeries of the urinary tract. We're going to also look at their voiding patterns. If they're peeing less than 4 times a day, that could be that they're not voiding enough because they have urinary retention, which then increases your chances of developing UTI. Or if they're urinating frequently, more than 6 times a day, that could mean that they have an active UTI going on. Then the signs and symptoms, again, we're looking at urgency, frequency, burning, foul-smelling urine, hematuria, and pelvic pain. And then we're going to inspect the urine for volume, color, concentration, cloudiness, blood, and foul odor, because these are some of the signs and symptoms of a UTI that's active. And then we can also review the urinalysis and culture results to see if there were presence of bacteria in there. The nursing diagnoses are acute pain, impaired urinary elimination, and ineffective health maintenance behaviors. The nursing care that we would do for a patient with UTI is administer antimicrobials as ordered. Antimicrobials meaning if it's a bacterial infection, we'll give an antibiotic. If it's a fungal infection, we're going to give an antifungal. We're not switching it up. We're administering the antimicrobials as ordered. We also provide pain control or comfort measures such as applying heat or giving a urinary analgesic. In this chapter, the urinary analgesic you have to know for the exam is called phenoxyperidine. That's spelled PHENAZOPYRIDINE. It's pronounced phenoxyperidine, and it's specifically given for patients who are experiencing painful symptoms of UTI. You have to know this medication for the exam. Then we're going to monitor their symptoms and monitor their intake and output to make sure that they're doing okay as they're recovering from the UTI. The teaching that we're going to give is that they have to take all of their antibiotic or antifungal as prescribed, because if they don't, their UTI can come back with a vengeance, and it's possible for the infectious agent to develop drug resistance. We're going to ask them to increase fluids because we do still want the urinary system to flush out as much of that pathogen as possible from the bladder. And then we're going to teach the patients to recognize and report when they have UTIs. And then we're also going to look for ways to prevent a UTI from happening in the first place, such as can we avoid putting in a urinary catheter for this patient at all, because that would be best practice. Now, separate from UTIs, another category of urinary disorders would be urological obstructions, in which there is obstructive urine flow. And so urological obstruction is the umbrella term, and then underneath was different subtypes. Urological obstructions always are significant because they will always lead to some sort of complications. And the urological obstruction can be partial or complete, or they can be also unilateral or bilateral. Unilateral will mean that it impacts one of the kidneys or one of the ureters. Bilateral would mean that it impacts both kidneys or both ureters. Partial obstruction obviously means that there's some opening so that the urine can flow. It's just a very small opening. Whereas complete obstruction of urinary flow would mean that it's not flowing out of that ureter or out of that kidney at all. Urological obstructions can develop rapidly or slowly. It just depends on the cause. And the issue with urological obstruction is that urine is supposed to flow in one direction. It's supposed to flow out of the kidney, into the ureter, into the bladder, and then out of the urethra. But if there was some sort of blockage somewhere, urine can certainly back up all the way back into the kidneys, which then would increase the amount of pressure in the kidneys. And if left untreated, that can cause chronic kidney disease. But while in the short term, if you've had urological obstructions for a couple of days that has been going untreated, it could, on the short term, cause a condition called distended kidney known as hydronephrosis, which we will talk about in a later slide as well. So we have urological obstructions as the umbrella term. One of the first things underneath that is urethral strictures. Urethral, obviously meaning the urethra. Stricture is a term used to say that there is a narrowing of a non-blood vessel. So there's a different term for when blood vessels narrow, but when urethra, which is a non-blood vessel but is still very tube-like, is narrow, it's called urethral stricture. And so there's narrowing due to scar tissues in the urethra, and the causes of these scar tissue could be injury, STIs, tissue trauma from catheters or surgical instruments, cancer, and enlarged prostates for men. The incident is that it happens more in men than women because men have prostates, as well as, men can also be impacted by some of these other things. But the signs and symptoms of urological obstruction is generally going to be a diminished urinary stream, meaning that the stream is somehow very thin or very and not very strong. There could be dysuria, which means painful urination, frequency, and frequent UTIs. And the treatment for that would be catheterization, in which we insert a urinary catheter, or it could be urethral dilation, in which we use an instrument to push inside the urethra and then expand the urethra. Endoscopic urethrotomy. Otomy means to make a cut. Urethrotomy is making a cut in the kidneys using an endoscope, which then would make it minimally invasive. However, the issue with urethrotomy is that it's generally trying to scrape out the scar tissue. And because scar tissue form as a result of injury, a lot of times the urethrotomy is going to cause more injury and therefore cause more scar formation. Then you could also have a urethroplasty, in which the surgeon completely kind of repairs the urethra, potentially using other tissue in your body to remake the urethra. And then you could also put in a stent, which is a mesh tube that helps hold up the walls of the urethra in order to keep it open. Now, another subcategory of urological obstructions are renal calculi, also known as urolithiasis. So I want to make a quick highlight that renal means kidney. Excuse me while I write with my mouse, but the renal part of this word means kidney. Calculi is a term used to describe stones, specifically stones made of calcium. A lot of times, renal calculi is directly translated as kidney stones for the average person, and that way they know exactly what they're talking about. But the medical term for kidney stones is renal calculi. Generally, calculi is used just to describe stones, but really it came from the word calcium, which is a lot of times the basis for a lot of these stones. If you ever run a test for kidney stones, the composition of the kidney stone is that it's going to be made up of mainly calcium. But if it's made up of other things, then we would just call them stones. Urolithiasis is a more broad, all-encompassing term. Uro obviously meaning urinary system. Lith, L-I-T-H, is the Latin the root term for stone. And then iasis is a state of. So urolithiasis is when is a more broad term for kidney stone. Kidney stones, renal calculi really refers to stones made in the kidney that are mostly made of calcium, but you can have stones in other parts of your body, and they are not always necessarily made of calcium. And so urolithiasis is a more broad term describing stones occurring anywhere in the urinary system. So these are hard, small stones in the urinary tract. Calculi is a term for stones. And if the stone is forming in the kidney itself, it's called nephrolithiasis, which are more appropriately translated as kidney stones. If the stone occurs in the ureters, it's called ureteral lithiasis, which literally translates to ureter stones. So this is a picture of what it might look like to have stones in your urinary tract. And the stones can form in the calyx, which is the small funnels in the kidney. Then it could be broken free and then end up in the pelvis, which then will go down into the ureter. And then that stone can get stuck in the ureter. If that happens, there would be a backflow of urine in that particular ureter, and the ureter will develop a condition known as hydroureter, meaning hydro meaning water, ureter meaning ureter. And so hydroureter, you can think of it as waterlogged ureter, meaning there's way too much fluids in that ureter and it's causing backup and also changing the structural integrity of the ureter itself. If the stone is forming in two different calyces and they're merging in together, it's known as a staghorn stone, which is shown here on the left. Staghorn meaning that they have horns almost like a deer. And then you could have bladder stones, which should be known as cystolithiasis. It's in which the stones form in the bladder. And then you could also have urethral stones because you were trying to pass the bladder stones. The pathophysiology of how stones are formed is that there's too much concentrated urinary salts sitting in the urine. This generally happens in one of three ways, in which either the urine is too concentrated, because when you have a small amount of urine and you're not drinking a lot of water, you're dehydrated. If you're dehydrated, you're not going to produce a high amount of urine. When you only produce a small amount of urine, all the urinary salts, all the waste products that are inside of that small amount of urine is going to sit closer together because there's not where anywhere to go, right? There's no room for the urinary salts to sit somewhere else. So because there's not enough urine, the urinary salts are too close together. When the urinary salts, which are also just another name for nitrogen waste in the urine, when they sit too close together, they're called salts because they can crystallize. And so some of these waste products will bind with other waste products and form a salt, which then can further crystallize. And so one issue is that if your urine is too concentrated, these waste products are sitting too close to each other inside of that small amount of urine. And when they're in close proximity, they can crystallize and form stones as a result. Another reason why kidney stones may form in the urine is that there are substances that prevent the formation of stones that you're supposed to also be able to excrete out in your urine. These are generally found in whole foods, such as fresh fruits and vegetables or unprocessed meats. And so if you're not intaking a balanced diet of like fresh fruits, vegetables, and fresh grains or fresh meat and things like that, you could be depriving your urine of substances that prevent the formation of stones in the urine. And therefore, it's going to increase the risk of these stones crystallizing in the urine. Then the last one is that there are waste products that form crystals and bind together. That is the entire basis of how kidney stones form. And so these three things combined together makes your chances of developing kidney stones really, really high. These stones can form the kidney, ureter, or bladder. If the stone is less than 5 millimeters in diameter, they're usually easy to pass. To give you an idea, one single grain of sand is generally about 2 millimeters in diameter. So you're looking at, 2 or 3 grams of sand binding together like that. That's usually okay. You can probably still pee it out without any issues. But if it's 3 or 4 grams of sand binding together and you're passing that through your urinary system, that has now gotten a lot bigger and can cause tearing on the inside as you try to pass these stones. Larger stones can be painful and require treatment, and we'll look at what some of those treatments are. But the etiology or how the stones are formed is that sometimes if your parents had stones, you may be more likely to develop kidney stones as well. There could be chronic dehydration because, like I said, if you're not producing enough urine volume, then all of these urinary salts are going to sit too close together and crystallize. If you have a diet that's high in sodium, sugar, and protein, well, last chapter we talked about how protein is made of amino acids. And when you have excess amino acids, you're going to get rid of it through your urine. But because the name suggests it's an acid, when you excrete too much amino acids, it's going to cause acidity. There's going to be increased acidity in the urine. Sugars and salts are also excreted when there's too much of it, and they can also they can also increase the acidity of the pH of the urine. And so these are all things that can cause there to be more stone formation in the urine. Obesity is generally because if you're obese, you're probably eating a diet that is high in sodium, sugar, and fat and proteins. And you're probably not drinking a lot of water. And so these are how ways obesity can contribute to the formation of kidney stones. If you have infections or recurring UTIs, there's a certain strand of UTI that can also cause stones to form. There's like a very specific stone that it will form as a result of having this UTI. And so that could be another reason why. But diabetes, hypertension, and gout. Diabetes and hypertension, we talked about how it increases the pressure in the nephrons, and so therefore it can cause the nephrons to burst and be damaged, and then you wouldn't have as much filtration anymore. Gout is actually a very similar disease process to kidney stones. So kidney stones, we said, is that there are too many nitrogen wastes in the urinary tract. And so they're all sitting together really closely, which allows them to crystallize and form stones. Your body obviously has to try to get rid of those waste products. And one of the ways that we get rid of it is to make sure to flush it out with urine. But if you have some sort of urinary disorder where you can't flush out a lot of these waste products, the body will then try to choose another place where we can deposit this waste product in order to do the least amount of damage. So if kidney stones is trying to get rid of the waste products in urine, gout is when we have nowhere to put that waste product because we have too much of it because the kidneys aren't filtering them out. Then your body is going to deposit them as far away from the rest of your organs as possible. And so a lot of times they end up getting deposited in the feet and the joints of the feet. That condition is known as gout. So gout is when we get rid of our excess waste in the feet where we can't actually get it outside of our body. And then kidney stone is when we try to get rid of the waste in the urine. However, unfortunately, because there's not enough urine, they actually create formation of stones instead. Renal calculi tend to happen more in men than women. And so that was just something that was in your book. The signs and symptoms of kidney stones are, it depends on where they're located. If the stone is in the kidney itself, known as nephrolithiasis, there's going to be costovertebral angle pain again because the issue is now inside the kidneys. And then there could also be hematuria. If the stones are located in the ureters, you could have flank, side, or lower abdominal pain, depending on where in the ureter this is impacting. The pain can be so bad that it radiates to the genitalia. And in fact, I've heard women who've given birth, vaginal birth, compare the pain from vaginal birth to passing a stone. And some women have said that passing a kidney stone feels way worse than pushing a baby out. And so there's also intense urge to void because remember, there's a backup in the urinary tract somehow. And so your body really wants to flush it out. There could be frequency, dysuria, and reduced output because, again, there is blockage, and there could be hematuria or blood in the urine because these stones are tearing up the insides of your urinary tract as they are passed. And so, therefore, some red blood cells are going to end up in the urine as a result. There could also be nausea and vomiting simply from how painful it is to pass a kidney stone. So, signs and symptoms, if the stones are located in the bladder, there's generally going to be hematuria as well. And there could be oliguria, which is low urine output. because of the obstruction of the bladder outlet. This is a picture of some stones that people have found inside of other patients. Some of them you can see are just almost sand-like, sand grain-like. Those probably don't need a lot of intervention. We just need to be able to flush it out. However, as the stones get bigger and bigger, you also notice that some of them are kind of smooth. And the reason for that is because, as you know, if a stone is rolling down a hill, it's kind of the hill itself is helping smooth out that stone. These stones are so smooth because they're trying to pass through the kidneys into the ureter and the bladder and then into the urethra. It's getting smoothed out by your urinary tract as it passes through your urinary tract. So these three big chunky stones in the lower right corner, they're probably removed from the bladder through surgery because otherwise there's no way you can pass a stone that is that big. With kidney stones, the best thing to do is to prevent them from happening in the first place. And as you can imagine, the three ways to prevent it or minimize the risk is to hydrate, keep up a good diet, balanced diet, and then also exercise. The hydration and diet, I think, makes sense just given what we know about kidney stone formation. But the exercise part is actually really interesting. And here's a couple of different ways to look at this. When you exercise, you actually increase the circulation of blood in your body, which generally allows for improved function throughout your body. And so when you're exercising, it actually increases pressure in the kidneys, which allows for filtration to happen more effectively without damaging the nephrons. And so exercise actually allows your body to get rid of waste products more effectively through urine, as well as increase the functionality of your other organs as a result of increased circulation. Plus, I think if you're somebody who regularly exercises, you're more likely to be aware of what you're eating and drinking on a day-to-day basis. And so, these are just really lifestyle choices that if you're going to be somebody who wants to hydrate, you probably also care about your diet and your exercise regimen. But if you're someone who cares about your diet, most likely you are someone who also drinks enough water and then does enough exercise to balance that. So these are really the three things that we ask patients to do a lot of times in order to be healthy. And so no wonder they're going to help with keeping kidney stones to low levels, right? Now, some of the diagnostic tests you could do in order to see if the patient is currently developing a kidney stone or that they're happening inside of their body is that you can draw their blood and check for calcium levels, uric acid levels, blood urea nitrogen levels, and creatinine levels. These are some ways to measure the waste products that are in your blood to see how much of it actually makes it to your kidneys to be filtered out. You could do here urinalysis for hematuria, crystals, and urine pH because the more acidic the pH, the more likely crystals are to form. And then you could also do a 24-hour urine collection because, like I said, it's important to know what is your kidney's baseline function when you're not exercising or going about your day. And so we might want to look at, what is the quality of the urine that is produced overnight when there's not a lot of activity going on. You could do a helical computed tomography scan in which we do a CT scan of your lower abdomen to see if there are any stones in the urinary tract. You could do a renal ultrasound, you could do abdominal x-ray, you could do an IV pyelogram, which are all things we talked about from chapter 36. The therapeutic interventions for stones that are relatively small, and I guess we could define small as being 5 millimeters or less, we're just going to increase their hydration. We're going to give them analgesics if they're in a lot of pain from passing one of the stones. And then we can also give them a alpha blocker medication known as tamsulosin. Tamsulosin allows the urethra and the ureters to open wider. If they're going to open wider, then the stones are going to have an easier time passing. For larger stones that are causing the patient a lot of pain, we generally push IV fluids to further dilute their urine. We offer them pain control, and some of them could be receiving opioids because of how painful it is. We can give them thiazide diuretics to force them to secrete more urine in order to dilute their urine and make the passing of the stones easier. We can give them a medication called allopurinol, which helps with binding. Allopurinol will bind to the waste products themselves in order to make filtration happen a little bit more easily. Allopurinol, speaking of which, is actually a gout medication as well. We talked about earlier how gout shares a similar process as kidney stones. And so, of course, it makes sense that a medication that works for gout might also work for a patient with kidney stones. Then we can do something called lithotripsy, which is extracorporeal shockwave therapy, known as lithotripsy. Extracorporeal in this sense means outside of the body. And so in this case, we actually, I believe we put them under twilight sedation and have them lie down. And then we expose them to high frequency shockwave in order to break the stones up through vibration. Now, if lithotripsy, for whatever reason, doesn't work for you, there are other ways we could do this as well, including doing surgery, such as cystoscopy, in which we insert a scope into the bladder. We can also do cystolitholipaxy, in which we crush the stone with an instrument, insert it into the bladder via the urethra. A lot of times, cystoscopy and cystolitholipaxy happens at the same time. Then we could do cystotomy, in which we cut into the bladder in order to remove a pretty large stone. We can also do something called a percutaneous nephrolithotomy. Otomy meaning to cut into something, nephro meaning the kidney, lith means stone. So percutaneous nephrolithotomy is where we cut into the kidney to remove the stone through the skin. Percutaneous means to go through the skin. Once you have a percutaneous nephrolithotomy, you're generally also going to be given a nephrostomy too. Ostomy meaning an artificial opening. So a nephrostomy opens directly into the kidney in order to allow for drainage. We could also do something called nephrolithotomy, which is just a removal of the kidney stone, but at this time it might be done through a scope inserted, or it could be just another way to perform the surgery using an actual incision instead of going directly through the skin. Then you could have pyelolithotomy and ureteral lithotomy, in which you cut into either the renal pelvis or the ureters in order to remove that stone. The complications of kidney stones are UTIs, hydroureter, which I said was a backup of fluids into the ureters. You could also have hydronephrosis, which, as the name suggests, means a fluid backup into the kidneys. You could have shock as a result, you could have sepsis, and you could have chronic kidney disease as a result. Now, some of the nursing diagnoses are acute pain, risk for infection, and deficient knowledge. And in order to collect data to see how the patient is doing or tolerating the kidney stones, we're going to do a health history. We're going to ask them things such as, did you recently have any sort of UTIs? Do you have any sort of renal impairment? Do you have diabetes or hypertension? Things like that. We're also going to monitor their vital signs, specifically their temperature, because sometimes it could be causing a UTI, in which case then they may have elevated temperature. We're also going to monitor them for pain and strain their urine in order to see if there's any stones that will be caught during the straining process. And then we could measure their intake and output and monitor their symptoms. The nursing care for patients with kidney stone is to manage their pain because, like I said, it can be an extremely painful disease. We're going to strain all their urine to see if the stones are getting bigger or smaller, or the stones are getting less in numbers. These are all signs that it could be the kidney stones could be improving. We're going to make sure that they stay hydrated and potentially monitor their intake and output, as well as their water weight or their daily weights. And then we're going to teach them on ways to prevent the formation of renal calculi to begin with. Now, as I said earlier, hydronephrosis is a complication of urological obstruction. So this obstruction causes urine to back up into the kidneys, and then the kidneys enlarge as urine collects and sits in there, which again increases the pressure of the kidneys And then at that point, damage to the kidney is possible because what's happening is that those tubules in the glomerulus in the nephrons are so tiny and so small, they can't handle very much pressure. And so if we're putting too much pressure on the kidneys as a result, then kidney damage is certainly possible. And we're also going to treat the cause of the hydronephrosis because, like I said previously, hydronephrosis almost never happens on its own. It generally happens as a complication of urological obstructions. This is a picture of what hydronephrosis might look like. On the left, you have a completely healthy urinary system. In the middle, you have a urinary system with moderate amount of hydronephrosis, in which you can see that the walls of the bladder have actually thickened, and so have the walls in the urinary ureters. And I actually point this out because this is what I mean by waterlogged. Waterlogged in this sense means that there's fluids backing into the third space of the cells. And so water is getting into the cells that make up the ureters as well as the bladder, which causes them to swell. And so this would be hydronephrosis, in which there's a lot of water logging in all of the organs of the urinary system. And then on the right, you just have an even worse picture of hydronephrosis, in which now you have very thick walls of the bladder. The walls of the ureters got thin again, but that it doesn't mean that they don't have a lot of water backing up into it. In fact, a lot of that water is backed up into the kidneys themselves. And because of how waterlogged all of the organs in the urinary system have become, you can see that it actually effectively shrinks the size of your bladder. So the amount of urine you can hold in your bladder decreases as a result of hydronephrosis. Signs and symptoms of hydronephrosis are going to be frequency, urgency, and dysuria, as well as flank and back pain, just because of where everything's located. The therapeutic measures is to treat the cause, and we could potentially put in a urinary catheter to allow for more drainage. We could put in a stent if the issue was urethral stricture. We can also put in a nephrostomy tube. A nephrostomy, again, is an opening directly into the kidney, and we could put a tube into that ostomy in order to allow for more drainage from that particular section, that particular part of the urinary system. If we put in a nephrostomy tube, we have to make sure that there's no kink, no dependent loops, and no clamps that are being used, because again, we need a way for the urine to flow out. So if it's clamped or has a kink in it, the urine is not going to flow out of the nephrostomy tube freely. We want to measure the intake and output of a patient with hyperhidrosis, and in order to do so, we have to report the urinary catheter's volume and the nephrostomy tube volume separately. The reason why we have to do that is because it is possible to have both a nephrostomy tube as well as a urinary catheter, because as you can see in this picture, the tube isn't going to capture every single drop of urine because it's a tube in a funnel. And so some urine is still going to bypass the nephrostomy tube and get into the ureter in order to drain out. So if that happens, we want to have something in the bladder that can catch that. Not only that, a nephrostomy tube sometimes is located only on one side, but not the other. So for the healthy kidney that is not affected by hydronephrosis, that one could still be producing urine regularly and forming urine in a very productive way. But then if you combine the nephrostomy output with the urinary catheter's output, you won't know if the kidney with the hydronephrosis is improving, because the urine specimens will mix together. And so it could look like that the urinary system is now okay, even though it could just be because the healthy kidney that is still healthy is picking up the slack of the kidney that has hydronephrosis in it. So with the nephrostomy tube, if you have both a nephrostomy tube and a urinary catheter, or if you even have two nephrostomy tubes, one for each kidney, and then a urinary catheter, you actually have to record the two nephrostomy tube as separate outputs, and then you also have to keep the urinary catheter output as its own category. So if both kidneys have a nephrostomy tube, you cannot combine the specimens from both nephrostomy tubes. You have to record them separately because one of them could potentially still be healthy while the other one has hydronephrosis and therefore is not functioning as well. Now moving away from nephrostomy and kidney stones, we're going to go on to bladder cancer. Bladder cancer is the most common type of urinary tract cancer, and it occurs in men more than women, generally found in patients aged 50 to 70 years old. The etiology, or how you can develop bladder cancer, is if you smoke or inhale a lot of industrial pollutions. These are you intaking way more toxins from the environment than somebody who doesn't smoke or doesn't live in an area impacted by industrial pollution. So the more you smoke, the more you expose your body to toxins. And these inhaled pollutants pass from the lungs into the kidneys and collect in the urine, where they sit in the bladder for maybe a couple of minutes, but maybe an hour or so before you can actually pee. So all of these toxins are sitting in this urine, and this urine is touching the inside wall of the bladder, which then allows the damage from the toxins to happen to the inner walls of the bladder. Which, just so you guys know, the bladder is a smooth muscle similar to the smooth muscles of the GI tract. However, the inside of the bladder is lined with a membrane called epithelial cells. Epithelial cells are actually very similar to skin cells in your skin. And so epithelial cells, the issue with epithelial cells is that it can mutate as a result of cancerous processes. And so you're inhaling all these pollutants, they're toxic for you, they get into the kidneys, they get filtered out by the kidneys, and they're now sitting in the bladder as urine waiting to come out. These toxins are going to touch the epithelial cells of the bladder and cause genetic mutation to the cells of the bladder, and therefore causing potentially bladder cancer. The signs and symptoms of early bladder cancer is actually painless, and that there's maybe hematuria. So there's painless hematuria, and so it means you're just bleeding into your urine for no reason. This means that most people don't seek medical attention until the bladder cancer has advanced and become more severe. As it gets to the later stages of the bladder cancer development, you're going to have more episodes of hematuria. And at this point, you could also have bladder irritation, which is things like pelvic pain, distension, pain with palpitation in the lower abdomen, things like that. You could have a fistula formation. Fistula refers to a connection that is not supposed to happen between two organs. In your book, I believe it said that it's very likely for the bladder to develop a fistula with the GI tract, because the GI tract is kind of around the bladder. And so let's say this is my GI tract. It's kind of crazy GI tract, but whatever. What could potentially happen is that the bladder cancer will erode through the layers of the bladder, as well as the layers of the GI tract around it, therefore causing there to be a connection between the two organs that are not supposed to be there. So that would be what a fistula formation is. It's when two organs are connected together in a way that they're not supposed to be normally. And that's generally because your cancer cells in your bladder can cause cancerous changes to other tissue around it. And therefore, you can make those two organs connect to each other through fistula formation. You could also have pelvic pain, lower back pain, dysuria, and an inability to void, and because there's urinary retention from blood clots. So when it's early signs and signs and symptoms of bladder cancer, you have hematuria, meaning that there's red blood cells mixed in with your urine, and that urine is probably sitting in your bladder, just waiting to exit. When the red blood cells in the urine has been sitting there for too long, they will clot together, and then those clots can potentially clog the urine outlet in the bladder. And so it's almost like having a clogged sink because you have just too many things floating around in the sink, maybe scraps of food and things like that. So cancer of the bladder, this is what it usually looks like for diagnostic testing to confirm whether or not this patient has bladder cancer. We can do a cystoscopy and transurethral biopsy, in which, as the name suggests, we put a scope into the bladder. We look around to see if we can see actual cancerous changes, because sometimes it is possible to visually see it. If we see it, we're going to make a snippet using that scope. These scopes usually have almost like tiny robotic arms attached to them so that the surgeon can see what they're grabbing as they are working with the scope. Then we could use urinalysis to detect the presence of blood. And a lot of times we'll do both cytology and a urine culture because a lot of the UTI symptoms are also seen for bladder cancer. Bladder cancer and UTIs have an overlap of their symptoms. So cytology, we previously talked about that it's the study of cells. So we take that biopsy, we process it in the lab so that we can see what the cells look like under a microscope. So this is a picture actually of normal urothelial cells. Urothelial meaning it's the skin cells that are inside the bladder. These are normal urothelial cells which have uniform appearance with abundant cytoplasm and small nuclei. So you can see that the dark dots that are inside the cells are the nuclei. And what you are actually seeing is that the cells are uniform, meaning they're about the same size, they're stacked together in a similar way. And so that's how we know that the cells in this bladder are healthy. On the right, you have a picture of cytology of high-grade bladder cancer, in which the cells are enlarged with large and dark nuclei. Here's how cancer works in your body. Your cells, each of them have a nucleus, which the nucleus provides instructions on when that cell can divide and multiply in order to grow. So you want your nucleus to look like small dark circles for most of the majority of the life of the cell, unless it was dividing in order to create more cells. In cancer, the nucleus has lost control of how much and how often to multiply and grow at the same time. And so, in something like cancer, such as bladder cancer, your cells have now undergone a mutation. And so, the nucleus in the picture are dark and enlarged because they are constantly splitting. Normally, there's a number of days that, your cells are good for before the cells around it has to split and multiply in order to replace some of the cells that you lost just through normal aging changes. In cancer, the nucleus has lost control and is now multiplying like crazy without any regards for the cells around it. That's why the nuclei in the picture on the right are much bigger and harder to differentiate from each other because some of these are still literally still multiplying while this picture is taken. In your book, it talks about urine tumor markers that we can collect in order to see if the patient has developed bladder cancer. However, I feel like this is a little bit outside the LPN scope of practice, and so I don't really necessarily think you need to know it for the exam. You definitely don't need to know it for exam 3. And I also don't think these tumor markers generally show up on the NCLEX. So that's why I took it out, but that's another test you can do in order to see if somebody has bladder cancer. And then the last one would be imaging, such as a pyelogram potentially, or a CT scan, an MRI scan, an X-ray, an ultrasound. These are all potentially ways for us to see if there's bladder cancer going on. Now, therapeutic interventions, you don't have to know the therapeutic interventions for bladder cancer because, like I said, it's a little outside the LPN scope of practice. It's definitely not going to be on exam 3. Bladder cancer itself is going to be on exam 3, but the treatments for bladder cancer won't necessarily show up. But anyway, some of the treatments for bladder cancer is known as intravesical therapy. Intra meaning within, vesicle meaning sac-like. So intravesical means within the sac, meaning within the bladder. You can do chemotherapy in which you introduce the chemotherapy agent into the bladder using a urinary catheter. We let the chemotherapy sit inside the bladder for about 30 minutes before we allow the patient to urinate it out. And so that would be chemotherapy. But as you know, the issue with chemotherapy a lot of times is that it's non-selective for how it kills the cancer cells. And so sometimes it will also end up killing healthy cells instead. Immunotherapy, though, is a very cool concept for treating cancer. And in your book, it talks about something called Bacillus Calmette-Guerin therapy for immunotherapy. Basically, what happens in immunotherapy is that we take parts of the cancerous cells and then we put it inside of a virus and we put that virus inside of the body. The body's immune system is going to say, hey, this is a virus. We need to destroy viruses. So let's take this guy apart. So the immune cells destroys the virus and then gets inside and sees that it's made up of a bunch of cancerous materials. And that allows the white blood cells in your body to be trained to also recognize cancerous cells in your body. And so immunotherapy is more selective and more protective of the patient because it's not going to kill off any of the healthy cells. It only targets cancerous cells inside of our body. Photodynamic therapy is where we introduce an agent into the bladder, and then the cancerous cells in the bladder will soak up this medication, which makes it more vulnerable to light. Then we shove the instrument into the bladder in order to expose the cancer cells to a specific type of light, which activates the medication that was given in order to make these cells more vulnerable. So first we weaken the cells by giving it a medication that makes it more vulnerable to light. And then we expose those cancer cells to light in order to kill those cancer cells specifically. So photodynamic therapy also tends to be a little bit more selective in how it treats the cancer. Then the last thing that we can do is just to do surgery to remove the cancerous cells. We could do a cystoscopy and pyelogram with fulguration. What this means is that fulguration is the destruction using heat that is supplied through electricity. So we're basically burning off some of these cancer cells with electricity. We could use a laser in which we use the laser to pinpoint the cancerous cells in order to destroy them. We could do a robotic laparoscopic radical cystectomy. Radical in this sense means complete or total. So radical cystectomy means that we're removing the entire bladder. The way that we're going to do that is through minimally invasive surgery using a laparoscope as well as a robotic arm to perform the surgery. So that's what that one is really saying. And then because you don't have a bladder anymore, you now need some sort of urinary diversion. So that's what we're going to talk about next. There are a couple of different kinds of urinary diversion. Urinary diversion is the umbrella term, and underneath it, you have two categories. One is incontinent urinary diversion, which we're going to talk about next. The other is continent urinary diversion, which that's what we're going to follow up with. So in incontinent urinary diversion, we can create something called urostomy using an ileal conduit. Here's how the ileal conduit is created. We take a section of the ileum, that's the ileal part, and we make it into a conduit. A conduit is basically a tube that connects to two other tubes. So we use the ileum to make a tube to connect to the ureters in the place of a bladder. The issue with this is that you will have a stoma where urine is going to continuously pour out of the stoma, and the patient will have to have an ostomy bag at all times as a result. So here's what an ileal conduit might look like. You take a small section of the ileum, you take out the bladder, you fashion or repurpose the ileum, and then you have created an opening for a stoma that drains urine out of the body. This is known as incontinent urinary diversion because you have no choice or no control over when urine comes out. Because your kidneys continuously excrete urine, this ileal conduit will constantly drain urine out. Something that was also mentioned in the book that a lot of times the urine that drains out of a ileal conduit will look mucousy in general. And so it might almost look cloudy. However, this is not to be confused necessarily with an infection. The ileum naturally produces a lot of mucus inside of it. And so some of that mucus is going to get flushed out with urine. And so that's why you may see that with a patient with urostomy. It does not necessarily mean that they have a UTI. It just means that they have an ileal conduit and the ileum secretes mucus, which gets mixed up with the urine. Another surgical procedure is, and this falls under the continent urinary diversion. This procedure, known as an Indiana pouch, is more rare nowadays, or it's less common now, because not only is it kind of not a great option, because we have better options, but also it requires lifelong self-catheterization of the reservoir. So here's what the Indiana pouch looks like. In the Indiana pouch, what you do is you take a section of your large intestine. This section is known as the cecum. We take a portion of the cecum, we make it into a pouch, we connect the ureters to the pouch, but we also create another stoma using another section of the ileum. And so the Indiana pouch will drain into the cecal pouch in order to store urine. But in order to get the urine out of your body, you actually, as the patient, would need to catheterize into the stoma and then put the Foley catheter or the urinary catheter far enough to reach the cecal pouch in order to allow the urine from the cecal pouch to drain out. So although you may not necessarily need a urostomy bag, you will still have a stoma, which most people don't love the look of the stoma. The last most common urinary diversion now for a lot of people is the orthotopic neobladder. Neo meaning new, bladder meaning bladder. So neobladder means it's a brand new bladder. Orthotopic in this context means that we're taking out the bladder and replacing it with something else in its exact spot where the bladder used to be. And so this is the most common form of urinary diversion now, and it creates a new bladder from intestines and implants the ureters and urethra into the neobladder. This actually allows you to continue to pee through your urethra, which is obviously a really great way for patients to not feel self-conscious about having a stoma and an ostomy bag. So again, we're taking a small section of the small intestine and then suturing it together in order to make a pouch or a new bladder. And then we connect our ureters to the neobladder, and then the urethra still works. There's still a valve at the urethra where you can control it open or close, which then allows the patient to just urinate through the neobladder, through the urethra. Now, some of the nursing care for a patient with bladder cancer is to consult a wound, ostomy, and continence nurse especially if they have an ileoconduit or a Indiana pouch. We also want to provide pre and post-op for patients receiving these urinary diversion surgeries. We want to assist with body image coping because, as I said, if you have some sort of ostomy bag that is constantly draining urine, that could make people feel some type of way about it. And so we're going to assist with body image coping. We're also going to reinforce teaching, such as the care of urinary diversion and the skin, and then also signs and symptoms of infection, because that part of the body is no longer fully sterile. And so you're more likely to develop some sort of infection. Now, moving on to kidney cancers, the incidence of kidney cancer is that it's actually one of the top 10 cancers for both genders in the United States. Most kidney cancers are diagnosed after the age of 55, and men tends to have twice the amount of incidence of kidney cancer compared to women. We see a lot of that in urinary disorders, and did not look into it, but if I am not mistaken, women have a lot of protective hormones pre-menopause, and these hormones actually help us protect against certain cancers. Men obviously don't have the benefit of that because they don't have these female hormones in them, and so therefore they tend to develop more cancers simply because their body has not developed a way to protect against it. The risk factors of kidney cancer is also smoking, because we said that we could inhale these pollutants, and then the pollutants would pass from the lungs into the kidneys, and then the kidneys have to get rid of these pollutants. And so as it does that, some of these pollutants will still stay in the kidney itself, which then can cause the damage to the nephrons. Obesity tends to also be a factor, but again, we kind of talked about how with obesity, you're probably not very careful with what you eat or drink. You're probably not hydrating, and you're probably not um, exercising in order to keep yourself healthy. Hypertension is huge with kidney cancers because the tension of the kidneys what can happen is that uh, cancerous cells from other parts of the body will always pass through kidneys in order to be excreted, potentially. And so sometimes hypertension allows more carrying of some of these toxins into the kidneys. And so therefore, sometimes they could cause the cells of the kidneys to change as a result. Then you are generally on long-term kidney dialysis, because when you have cancer of the kidney, that kidney is no longer functioning. We could have exposure to radiation, asbestos, or industrial pollution, because again, these are all things that sometimes end up in the kidneys as we try to get rid of it from our bodies. And the exposure to the kidneys from these pollutants is what causes the cells of the kidneys to mutate and become more cancerous, just like how it caused the urothelial cells of the bladder to mutate as well. Now, some of the late and classic signs and symptoms of kidney cancer is hematuria, dull pain in the flank area, as well as a mass in the kidneys. And so these are all like a little late at that point when we discover it. We a lot of times don't discover kidney cancers until it has metastasized. This is due to the fact that the kidneys are highly vascularized and allow for more cancer cells to spread. So just like how when we talked about the UTI, if the infectious agent gets into the bloodstream, it's now going to circulate all over the body. When it comes to kidney cancers, because these cancer cells now have access to the bloodstream to travel anywhere else in the body, if cancer cells from one part of the body gets into another organ, a lot of times that cancer cell will tell the cells in that new organ to also become cancerous. That's why it's so important to destroy cancer cells as much as you can find them, because if you don't, one cancer cell can travel somewhere else and tell the cells of that other organ to mutate and become cancerous as well. The diagnostic types for kidney cancer is IV pyelogram, cystoscopy with pyelogram, ultrasound, CT scans, MRI, and then renal biopsy. It will be the renal biopsy that gives us definitive diagnosis that this is kidney cancer or this is not kidney cancer. So anytime we take a biopsy, it's generally because we want to know, hey, is this cancerous or not? And we have to look at it in a cytology slide. Some of the therapeutic interventions for kidney cancer is surgery, in which we perform either radical nephrectomy. Ectomy means to cut. Neph is the kidney, so nephrectomy would be a removal of the kidney, and radical means completely. So radical nephrectomy, we remove that kidney completely. We leave the other kidney inside the body. However, we can also do something called nephron sparing surgery. As you know, the kidneys contain 1,000,000 nephrons. So if you take out an entire kidney, you're now left with only half the amount of nephrons you normally would have. So in nephron sparing surgery, we just try to cut out the tumor and then we suture back the kidneys together and hopefully preserve the function of the rest of the nephrons in that kidney. And so that would be nephron sparing. We allow for the rest of the kidney to stay in because we need as much kidney cells and nephrons as we can get in order to keep ourselves healthy. So this is one way to do that. We could also do radiation therapy, immunotherapy, chemotherapy, which are all things I kind of talked about previously with bladder cancers as well. The nursing care of patients with kidney cancer is pre and post-op management care, as well as monitoring urine output. Pneumothorax is a condition in which there's air in the lungs between the tissue of the lungs and then the walls of the chest cavity or the chest wall. However, this is possible because of the kidney's proximity to the diaphragm. So earlier I showed you the picture of costovertebral pain, and you saw that the left kidney is a little bit higher than the right kidney. So now let's imagine that we had to do some sort of surgery with the left kidney in order to repair it or remove stones or remove kidney cancer. You can accidentally puncture the diaphragm as a result of doing this procedure. If that happens, you're going to develop a shortness of breath and diminished breath sounds on the infected side as a result of that. So pneumothorax is something we want to try and catch before or right after surgery in order just to make sure that they're not developing pneumothorax as a result of the surgery. And then we also provide education on ways to potentially prevent it or how to treat it. So now, here's an activity cue recognition. You are caring for Mrs. McDuffie, who's 45 years old and had a right nephrectomy today. You know absent breath sounds on the surgical side, which would be the right side, and what actions do you take? So this is an example of pneumothorax developing in the patient's lung. So we want to notify the healthcare provider right away, and then also perhaps call rapid response team because pneumothorax is a medical emergency. The patient, the rationale is that they may have a pneumothorax on the surgical side and requires emergency care. If they don't receive that, they could potentially die. Now, this is an SBAR report, and just really quick, you can read it, but I'm just going to tell you, how to write this SBAR. But as you know, everybody writes their documentation a little bit differently, and there's no one right way to document something. These are just exercises to help you develop the skill for writing documentation when you are caring for patients on your own. So still the same patient, they're admitted from the PACU after a right nephrectomy for renal cell cancer, meaning they had kidney cancer. She's alert, oriented times 3, and presently reporting pain 1 out of 10. Blood pressure is a little bit elevated. Apical pulse is 88 and regular. Respirations is 18, and temperature is 98.6 Fahrenheit orally. Breath sounds are clear on the left and were absent in the right prior to the insertion of a chest tube on the right in order to allow for lung expansion. Breath sounds are now clear on the right. Chest tube is patent and functioning well. The presence of a chest tube is to allow for the air where it's not supposed to be to drain out of the chest cavity in order to restore the size of the lungs itself. And so for the situation, I would say that the patient was where's the situation here? The patient had no breath sounds in the right, and so therefore necessitated the insertion of a chest tube in order to correct the pneumothorax. Their background is that they were admitted for right nephronectomy for renal cell cancer, and then for the assessment, we're going to include that she is alert oriented ×3, pain 1 out of 10, but we're going to record their blood pressure, their apical pulse, their respiration rate, and then their temperature. So that would be assessment. And then the recommendation would be to ensure that she maintains lung sounds in all four in the chest fields, and that her chest tube remains patent and functioning until all of the air has been removed from the lungs or from the chest. So, there's more for this patient. The bowel sounds are absent. The surgical dressing is dry and intact. Urinary catheter is draining clear yellow urine, 40 milliliters to 65 milliliters per day, depending on whether or not she's awake and drinking. And then an IV of dextrose 5% and 0.45% normal saline is running at 100 milliliters per hour in the left forearm. Dextrose 5% in half normal saline is a hypertonic solution. And so just a quick revisit from exam 1. And there's no swelling at the IV insertion site. So a lot of these things can go into the B in SBAR for background or for A in assessment. And so that's where I would stick most of this information. So the situation that is suggested by your book is talking about this 45-year-old right nephrectomy, and then who also developed pneumothorax with a chest tube insertion, which is similar to what I said. The background is that they have renal cell cancer. I would have added a little bit more to that, but just keeping it at renal cell cancer or kidney cancer is fine. Then the assessment is everything that we talked about. And then the recommendation is to continue postoperative monitoring, pain management, and reinforced teaching. Now, renal trauma. Trauma we know is some sort of damage done to the kidneys, usually from an outside force. For the data collection, we're going to see if there's a history of injury, and then we're going to inspect the abdomen and flank area. You might have heard that if somebody sucker punches you in the back, in the lower back, that's actually where your kidneys are. And so if somebody sucker punch you in the back of the lower back of your body, you might see bruising in the lower back, and you a lot of times may see hematuria as a result because the kidneys are so easy to reach through the back. The signs and symptoms of renal trauma would be bruising, swelling, pain, and hematuria, just like I said. The diagnostic test for renal trauma could be urinalysis, IV pyelograms, ultrasounds, CT scans, and MRIs in order to see what's going on. We're going to treat the injury and then monitor vital signs, intake and output, IV fluids, as well as pain management. We especially want to watch their blood pressure because, again, kidney damage can lead to high blood pressure. Now, moving on to another type of disease entirely, we have polycystic kidney disease. Poly meaning more than one, cyst meaning sac-like. So polycystic means multiple cysts on the kidneys. On the lower right-hand side, I have a picture of something that I grabbed from Google. That is what somebody's polycystic kidneys look like. And so there are multiple cysts in the kidney. This is a hereditary disease, so you don't just catch it randomly. You generally get it because your parents had the genes for it. The signs and symptoms of polycystic kidney disease is that there's dull heaviness in the flank or back area. There's generally hematuria as well as hypertension and development of UTI because the kidneys are not filtering properly with these cysts in the way. Polycystic kidney disease is progressive. There is no treatment for it. It will eventually cause chronic kidney disease in the patient, and either you get kidneys replaced or you start dialysis, which we'll talk about shortly. Now, another disease process of the kidney is diabetic nephropathy. In the last exam, we learned about diabetic retinopathy, which is disease of the eyes as a result of having diabetes. Diabetic nephropathy is when you have kidney damage as a result of having diabetes. It is a long-term complication of diabetes. It is most common cause of chronic kidney disease along with hypertension because as we learned from the last exam, diabetic retinopathy happens because all these uncontrolled blood sugar molecules look like shards of glass. And so when they're on the inside of your capillaries or your arterioles for the kidneys, it's going to really cut up the insides of some of these blood vessels, which then makes them more leaky and more prone to breaking. Once the blood vessel is broken, generally we can't really repair it. We can make new blood vessels to replace the ones that were broken, but these new blood vessels are never as good as the original blood vessels that they're trying to replace. So atherosclerotic changes decrease blood flow to the kidney. Athero meaning, I believe it just means blood vessels. And then sclero, you already know, is a hardening. So atherosclerotic changes, if I had to look that up, let me look it up really quick. Okay, with atherosclerotic changes, athero meaning actually the deposit of cholesterol or fatty deposits on the sides of the arteries. Arterial sclerosis refers to the hardening of the arteries or the arterioles. But atherosclerosis is a subset of arterial sclerosis in which there's a hardening of the arteries due to fatty plaque buildups. Arteriosclerosis can happen through other causes, but atherosclerosis is specifically hardening of the arteries due to fatty plaque buildup from having too much cholesterol. And so atherosclerotic changes decrease blood flow to the kidneys. So then chronic kidney disease can develop as a result of diabetic nephropathy. Therapeutic interventions for diabetic nephropathy are to control blood glucose and blood pressure, and then to restrict protein in the diet because some of this damage to the kidneys will allow protein to leak out of the bloodstream into the urine. Last chapter, we looked at how filtration happens in the glomerulus, and you saw that there's a little bit of these holes where water molecules and waste products can filter out, but blood plasma protein was too big to pass through. With diabetic nephropathy, the holes of the glomerulus become wider as a result of damage to the nephrons. And so therefore, the holes then become wide enough for plasma protein to leak into the nephrons instead of staying within the blood vessels. And so we want to restrict protein in the diet in order to prevent loss of these proteins. And we also want to control their blood glucose and blood pressure in order to make sure that they don't develop worsening diabetic nephropathy. However, if it's later on in the diabetic nephropathy, maybe they did a really poor job of controlling it, they may need to have dialysis. Dialysis is known as kidney replacement therapy because your kidneys filter out waste products 24/7. It never takes a break. However, you only go to dialysis 3 times a week. And so, and you're only there for maybe 4 hours out of the day. So in a total, maybe you go for 12 hours of treatment every week. But your kidneys are doing that 24/7. And so dialysis, if you don't do them, you will die. And it will usually happen very quickly because of the buildup of toxic waste in your body. And the patient may need a kidney transplant as a result because at that point you have kidney failure. If you don't use dialysis or get a kidney transplant, you will die as a result of having chronic kidney failure. The nursing care would be to reinforce the teaching of glucose and blood pressure control in order to prevent diabetic nephropathy from worsening into chronic kidney disease. Here's a picture of what it looks like when there's damage to the glomerulus. On the left, you have a healthy glomerulus. On the right, you have an arteriole that has been really damaged as a result of diabetic nephropathy. And so all these yellow little circles are protein that is leaking out of the blood vessels into the Bowman's capsule. And so that is going to end with protein in the urine. Now, moving on from diabetic nephropathy, you can have a disease known as nephrotic syndrome. This disease happens when a large amount of protein is lost in the urine from increased glomerular membrane permeability, meaning the glomerular membrane has become more leaky, allowing plasma protein to escape the blood vessels and go into the nephrons and then get collected in the urine. Serum albumin is a protein that flows in your blood, and the importance of albumin is that it prevents your blood vessels from becoming more leaky. It's what helps the plasma in your blood to stay within the blood vessels instead of leaking out into the interstitial space, meaning the space between cells. And so, because you're losing protein and albumin is a protein, your albumin levels will decrease, which causes more edema. Earlier, I said that albumin helps keep fluids such as water within the bloodstream by making the blood vessels less leaky. But if you have less albumin, then there's nothing keeping your blood vessels from leaking. And so if your albumin level decreases, the patient is going to have edema because now their blood vessels are leaking more fluids into the cells and tissues of the body. You could also have ascites. Ascite is a term used to describe accumulation of fluids in the abdominal cavity. And then you can also have a condition known as anascara, which I have to briefly pause to look up what exactly it was because I can't remember. Okay, have to look it up. So it's pronounced anasarca, and anasarca is a severe generalized swelling of the entire body. And that is obviously a very severe form of nephrotic syndrome in which you just have overall fluid loss into the cells of the body instead of keeping it in the bloodstream. And the liver will produce lipoproteins, which lipo means fat, protein means protein. So this is like a fatty protein in order to replace some of those albumin. However, anytime you have protein in the urine, whether it's the albumin form of protein or it's these lipoproteins produced by the liver, you're going to have foamy urine as a result. And here's the reason why. When you have protein in some sort of liquid and you whip it up, you're going to have foam as a result. So think about maybe if you were baking and you're whisking a bowl of eggs. If you whisk it fast enough, you will form stiff peaks with a bunch of foam. And so it's a similar concept as whisking a bunch of eggs. When you have a lot of protein in your urine, that urine as it's traveling from when you're sitting down the toilet and the urine, has to go through the air in order to land in the toilet bowl. The protein in the stream is going to catch little bits of air. And then as soon as it hits into the toilet bowl, that protein has captured air and now has formed foam in the urine. And so what I was getting at was that eggs are made out of protein. So when you whisk eggs, it's going to foam. Same thing with protein in urine. Although you're not whisking the urine, but because urine is going to pass through air as you're sitting down to pee in a bowl, it's going to capture some air, and because it's protein, it can form a structure. It's going to capture that air and become foam in the urine as a result. So foamy urine is a sign that there is protein in the urine. Then immunoglobulins and clotting inhibitors are lost because these are generally produced by the liver. And if the liver is too busy producing lipoproteins to replace the albumin that you lost, it's not going to keep producing clotting inhibitors or immunoglobulins, which can impact the immune system as well as cause potentially bleeding disorders for the patient. Then the treatment is to treat the cause and then manage the symptoms. So nephrotic syndrome is generally a form of kidney disorder and generally doesn't happen on its own. It generally happens as a complication from another kidney disease process. And we may give them anticoagulants to prevent the formation of thrombosis. The reason for that is because clotting inhibitors prevent the formation of clots. So if you don't have enough of that in your body is more likely to form clots randomly, which could become a thrombosis or an embolus, which is a traveling blood clot that can kill you. So we give those patients anticoagulants to prevent the formation of blood clots in a patient that is undergoing nephrotic syndrome. So nephrotic syndrome will show up on the exam. So will some of these other kidney diseases, such as diabetic nephropathy, polycystic kidney disease, as well as some of the other ones that we're still going to go through. Okay, so the nursing care for a patient with nephrotic syndrome is to check them for edema, and do their daily weights, intake and output, measure their abdominal girth, and then protect the edematous tissue. The edema that some of these patients will have is going to be known as a weeping edema, meaning that when you press in their skin, not only is their skin going to pit, their skin is going to also leak fluids. And it's doing that because there's no albumin keeping the fluids within the blood vessels. And so these fluids are just leaking out into the cells. And then if you put pressure on these skin cells, then the excess fluid is going to further leak out. And then so we have to be protective of the edematous tissue. We don't want to constantly press on it. We're going to prevent infection because when they have nephrotic syndrome, they're more likely to also develop a UTI or other types of infection. We're going to prevent malnutrition by giving them lots of protein to replace the ones they're losing. And then we also want to prevent the formation of a blood clot because the liver may not be producing some of these clotting inhibitors to prevent blood clots from happening. Now, moving on to a different disease process, nephrosclerosis. Nephro is kidney, sclerosis means harden. So this is hardening of the kidneys. And this happens because of hypertension damaging the kidneys by sclerotic changes. When there's a lot of pressure in tubes in the body, the tubes will harden in order to handle the higher pressure. However, sadly, the hardening of these tubes also makes the tubes easier to break. So the therapeutic intervention for nephrosclerosis is to give them antihypertensive to manage their blood pressure. And the nursing diagnosis that we have for nephrosclerosis is ineffective health maintenance behaviors. And between you and me, I don't think nephrosclerosis is on exam 3, if I remember correctly. Glomerulonephritis will show up on the exam. It is an inflammation of the glomerulus itself, which is the Bowman's capsule of the glomerulus. But it could also be happening to the blood vessels inside those afferent arterioles can become inflamed and swell. This makes the glomerulus or the Bowman sac more porous, meaning more things that are supposed to stay inside the bloodstream are going to leak out as a result. Antibodies form complexes that damage the basement membrane of the glomerulus, which is just another fancy way of saying there's some sort of inflammatory process where our body is attacking the glomerulus for some reason. And so as a result, protein, white blood cells, red blood cells can leak into the urine as a result. And the white blood cells are there because there's an inflammatory process. There's potentially even some sort of infection happening in the glomerulus. So the white blood cells are going to make their way over there to try and see if it needs to do anything. to repair or to kill off the infection. But this allows the glomerulus to leak out more protein, and then red blood cells and white blood cells may also leak out of the glomerulus and end up in the urine. So these are some pictures of what glomerulonephritis might look like, in which in the nephron there is an inflammation of the afferent arterioles, which causes vasodilation, leakage, increased warmth, and then pain as a result as well. And so this is then going to cause the urine that is produced to become foamy or bubbly and also pink or reddish in color because of the mixture of hematuria and protein in the blood, in the urine. And so on the right side is just another picture of glomerulonephritis where I show that there's inflammation in the glomerulus as well as the blood vessels that supply blood to the glomerulus. The causes of glomerulonephritis could be acute post-streptococcal infection. Strep throat can actually cause you to have glomerulonephritis after a couple of weeks. So let's say you have strep throat and it took you about 2 weeks to fight off the infection. After the infection has been fought off and your body has won, it now needs to get rid of all of this dead streptococcal bacteria from your body, and we need to flush it out. As you can imagine, we need to flush it out through urine. And so some of these dead bacteria will end up in the urine and kind of get stuck there because they're kind of big. And so they have a hard time getting into the glomerulus in order to be filtered out. So your immune system will then come over to the kidneys and say, hey, what's going on? Why aren't you getting rid of this dead bacteria? And then they'll see that, oh, it's too big to fit through the glomerulus, so I need to chop it down to smaller pieces. So these white blood cells are then going to be present in order to further break down the streptococcal bacterial corpses in a way in order to make them smaller to filter through the kidneys. However, that's going to take time. And in the meantime, you're not supposed to have any white blood cells in your kidneys, in your glomerulus. And so that's why typically after a strep infection, you may experience glomerulonephritis as the body tries to get rid of some of this dead bacteria from the streptococcal infection. You can also have something called Goodpasture syndrome, which I have to look up what that is again to remind myself what that might be. I have to look it up because there's a lot of information to remember. But Goodpasture syndrome is where there's a rare autoimmune disorder in which your immune cells attack the basement membrane of the kidneys. And so it can also happen to the lungs as well. So I think it can happen at the same time. If both happens at the same time, it's known as Goodpasture syndrome. And so we don't know exactly why the immune system attacks the kidneys as a result, but it generally happens in the kidneys in the glomerulus, which then causes glomerulonephritis. Then, if you have glomerulonephritis, you can develop into chronic glomerulonephritis, especially if you're someone who suffers from Goodpasture syndrome, in which, again, it's an autoimmune disorder. The signs and symptoms of glomerulonephritis is decreased urine output, known as oliguria, hypertension, electrolyte imbalances, edema, and flank pain are all possible. The diagnostic test for glomerulonephritis is elevated creatinine and BUN. And then they would also have dark urine that is foamy. Their urine analysis will come back with red blood cells, white blood cells, proteins, and casts. And then you could do an ultrasound to see what was going on, as well as x-ray or biopsy to see if that's what's happening in the glomerulus. Just so you know too, the cast in this in the urinalysis that you're going to see in glomerulonephritis, the cast is made of a shell of protein. And so it's called a cast because it doesn't actually contain a solid unit of protein. It's the shell of a protein that is made up of protein as well. So that's what the cast in urinalysis here means. Glomerulonephritis will show up on the exam, so make sure you know it really well. The therapeutic interventions for glomerulonephritis is that it usually will resolve on its own within 1 week. So we just do supportive treatment during that week. However, if it's really severe, then we're going to treat it like a kidney disease. The nursing care for glomerulonephritis is taking the vital signs. Again, we're really checking for the blood pressure to make sure that the blood pressure stays within normal range. We're going to support symptom, which is another way of saying supportive care or supportive treatment. And then the support that we're providing is providing more nutrients and rest to the body as the body tries to resolve this particular issue on its own. We're going to encourage lots of rest. We're going to encourage them to intake lots of fluid, sodium, protein. The patient would have fluid, sodium, and protein restrictions in order to not make the glomerulonephritis worse. And then we're going to educate them on how it happens and how to keep themselves healthy for that week in order for the body to repair itself from this illness. Now, acute kidney injury, as the name suggests, is a sudden loss of kidney function, and it can be from a variety of causes, but a lot of times it's generally from some sort of trauma. It could lead to something called azotemia, in which there's an accumulation of waste products in the blood. Mia means blood, so azote is another form of saying nitrogen waste. So azotemia is an accumulation of nitrogenous waste products in the bloodstream as a result of the acute kidney injury. They will become oliguric, which means that they produce less urine. The mechanism of this injury is that there will be, because of the injury, it causes hypoperfusion of the kidney, and then which can cause direct tissue damage as well as hypersensitivity to certain drugs or contrast dyes. Remember in the last chapter, we talked about contrast dye induced acute kidney injury. And so that's kind of what the hypersensitivity is talking about. You should recover from acute kidney injury because acute things should resolve within 3 months. So if we treat the cause or we take care of the patient, we can reverse the kidney injury until the kidney comes back to normal function again. There are 4 phases for acute kidney injury in which there's the initiating, then the oliguric, then the diuretic, and then the recovery phase. So with regards to these different phases, I can say that you don't necessarily need to know it for exam 3, but let's talk a little bit about them so that you're prepared for potentially seeing these on the NCLEX. All right, I went ahead and updated the slides with the different phases. These are on page 709 of your textbook. And I just kind of took a quick sentence or two from each blurb about the different phases of acute kidney injury, including the initiating phase in which the event causing the acute kidney injury occurs, beginning at the time of the injury and lasts until the occurrence of the symptoms, which can be anywhere between hours to days. The next phase is oliguric, in which there's fluid retention and electrolyte imbalance, which may result in fluid volume overload. May also result in metabolic acidosis, confusion, seizure, and coma. This is only experienced by about 50% of patients with AKI. The other 50% of patients would then skip the oliguric phase of the acute kidney injury. And so they may not have this. They would go immediately into the next stage, which we'll see shortly. But generally, this phase lasts anywhere between 24 hours to 7 days. The next phase is the diuretic phase, in which the kidneys begin to produce urine again and can produce anywhere between 1 to 3 liters per day. However, the kidneys have not yet become fully functional, and so it cannot concentrate urine, which then means that you're peeing out a lot, but you're not carrying all of those waste products out into the urine with you. So this then can result in a dehydration or hypotension. So we're going to monitor for the 4 hypos. Hypovolemia, which means low circulatory volume. hyponatremia, meaning low sodium levels, hypokalemia, meaning low potassium levels, and hypotension for low blood pressure. This phase, if the patient skipped the oliguric phase and went directly into the diuretic phase, can last 1 to 3 weeks for the patient. Then the last part is recovery, in which the glomerular filtration rate, which I accidentally typed as GRF, but I mean GFR, begins to rise. I meant to use the S. I don't know why I use a Z, but I am also recording this really late at night, so I think I'm just tired. So GFR begins to rise as recovery progresses. Waste products are greatly reduced, and this stage can last up to a year from the original time when the injury began. If the acute kidney injury does not go through these phases and go into recovery, it will generally progress into chronic kidney disease instead. So with acute kidney injury, the cause of it could be pre-renal failure, meaning something is happening in the body before blood gets to the kidneys. And so that could be a decreased blood supply to the kidney as a result of potentially some sort of shock. Because remember, the kidneys are not essential, and therefore we sometimes do not prioritize blood supply to the kidneys. There could also be intrarenal failure, meaning that something's happening within the kidneys to cause acute kidney injury. This is generally going to be something that's happening that's damaging to the nephrons that's happening within the kidneys. And that could be pointing to some sort of toxins or nephrotoxic drugs that is destroying the nephrons from within the kidneys. Then the cause of the acute kidney injury could be post-renal, meaning that it's happening as the urine is supposed to exit the body. So this is after it's been filtered out of the kidneys. And so we talked earlier about urological obstructions that can cause a backup of urine flow into the kidney, which will definitely result in acute kidney injury if it does backflow. Acute kidney injury can also be from nephrotoxins. So it could be from contrast medias and dyes. It could be from medications. IV aminoglycosides. Aminoglycoside is a type of antibiotics. Tobramycin, amikacin, and cistaplatin are other drugs that can be, if I remember correctly, these other drugs, the tobramycin, amikacin, and cistaplatin, are IV aminoglycosides. And so another kind of medication that can cause kidney injury is NSAIDs, especially things such as ibuprofen, aspirin, and naproxen. These medications are nephrotoxic if taken in large doses. So although these are over the counter, you can very well give yourself an acute kidney injury if you take too much of certain NSAIDs. And then obviously the last one would be some sort of chemical exposure. We talked about how pollutants can cause there to be kidney diseases. And so there could be certain chemicals that we're exposed to that would cause the kidneys to spend too much energy to excrete it out of the body. And so that could cause an acute kidney injury as well, where the cause of it is that we overwork the kidneys as a result of putting too much for it to break down and filter out. The prevention of acute kidney injury can be checking the GFR and serum creatinine prior to contrast media or nephrotoxic drugs. We talked about that last chapter, right? Because we don't want creatinine to compete with the contrast for clearance. We want to be sure that one can filter out and then the other won't interfere. We also want to follow protocols to prevent contrast-induced nephropathy or contrast-induced acute kidney injury. We want to hydrate before and after the contrast media in order to allow the kidneys to have more fluids to work with to filter these out. And we want to monitor peak and trough levels of nephrotoxic drugs per institutional policy. I've talked about peak and trough levels before, where the peak is the max that the drug can do in the body without overdosing the patient. And then the trough is the lowest amount of medication that can be in the body before it's completely washed out of the body and no longer effective. So if we follow peak and trough levels of these drugs for the patient, we're decreasing the amount of work the kidneys will have to do to filter these nephrotoxic drugs out. Therapeutic measures for acute kidney injuries to treat the cause and to provide supportive treatment and potentially dialysis, but dialysis does not have to be for the rest of their life. It could just be until their kidneys have recovered fully. And then we could also do continuous renal replacement therapy, in which we remove fluids and solids or solutes in a controlled, continuous manner in patients who are unstable. It is better tolerated by patients who are unstable, and the blood flows through a hemofilter. Excess fluids and solutes move into a collection bag out of the bloodstream. Now, moving into chronic kidney disease. This is the 9th cause of death in the United States because there is a gradual decrease in kidney function. A lot of times people don't realize that it's happening until it's too late and they may be at a step where they need dialysis. This is irreversible damage. Once your kidneys have developed chronic kidney disease, it means that several nephrons have already died as part of the result or part of the process. And so their GFR is going to be really low. And once a nephron dies, it cannot be revived, it cannot be replaced. And so if you have chronic kidney disease and your GFR is at 30, we will never be able to bring it back above 30 ever again. We would not be able to do anything to the kidney to cause the GFR to go back up to 50. And so this is an irreversible disease process. The etiology or the cause of it is generally diabetic nephropathy and uncontrolled hypertension, as well as nephrosclerosis, glomerulonephritis, as well as immune diseases in which the body attacks the kidneys themselves. The pathophysiology is, here's how it works. A large portion of the nephrons are damaged due to usually uncontrolled diabetes and hypertension. And so as one nephron dies, the rest of the nephrons have to pick up the work of the nephron that died. So now all these other nephrons are also being overworked. And so you have a progressive worsening of once one nephron dies, several more nephrons are going to die as a result of increased pressure as well as increased workload. This is also known as renal insufficiency, in which more than 75% of nephrons have been lost. It's known as end-stage chronic kidney disease if up to 90% of the nephrons have been lost. A lot of times this will end with uremia or urea in the blood, which, remember, urea is supposed to be one of the waste products that is filtered out in urine. And a chronic kidney disease will impact all body systems because every organ in your body is all working together. There's no one organ that doesn't rely on some other organ. However, the kidneys are one of those major organs where all blood supply has to flow through it in order to filter out waste products. And so when you have chronic kidney disease, you're also going to have other organ diseases as a result. The signs and symptoms of chronic kidney disease is usually fluid accumulation. They're generally going to have edema and shortness of breath and wonder where all this excess fluid is coming from. This is where it's helpful to measure the intake and output of the patient. If the patient is drinking more than they are peeing out, it means that there's something wrong with their kidneys, that they're not able to remove the excess fluids that we're drinking. There may be electrolyte imbalances in which there's elevated potassium, decreased or increased sodium. There could be hyper or hyponatremia as a result of chronic kidney disease. They may also have decreased calcium, but increased phosphorus. The reason for that is because phosphorus comes from processed foods, salamis, hot dogs, bacon, and things like that. We usually add phosphorus to these products to make them more shelf stable. However, when you have kidney diseases, you can't get rid of the excess phosphorus through urine. And phosphorus has an inverse relationship with calcium, meaning the more phosphorus you have, the less calcium you will have in your body. The more calcium you have, typically the less phosphorus you have in your body. However, because your body's not able to get rid of excess phosphorus through urine, it's going to retain the phosphorus. And then as a result, we're going to lose calcium from our bones because our body likes to bind calcium with phosphorus in order to allow us to get rid of the phosphorus through the GI tract. So the more phosphorus you have in your bloodstream, the more it signals the body to break down your bones for calcium in order to make calcium available to bind with phosphorus. So you're going to retain waste products. You may have acid-base imbalances as well as anemia, because remember, one of the functions of the kidney is to tell the bone marrow to produce red blood cells. So if your kidneys are not functioning very well, it's going to throw that part of the responsibility of the kidneys completely out. And so anemia results because we can't produce enough red blood cells, because in chronic kidney disease, we're also not producing erythropoietin. So these are some of the signs and symptoms of chronic kidney disease. In the oral cavity, they could have something called stomatitis, in which they have basically stomas or broken down sores in their mouth that is inflamed. They could have a bad taste in mouth because you can taste some of that excess waste products on your tongue if you've retained those waste products. Those waste products will taste bad to your tongue. And so if you have chronic kidney disease, you're not getting rid of excess waste. Some of that waste will end up on your tongue where you can physically taste it. In the cardiovascular system, you're going to have hypertension, which may potentially lead to heart failure due to fluid overload. You'll talk more about the different cardiovascular diseases in adult too, but heart failure is one where you have too much fluids in your body and the body cannot get rid of it properly. And so your heart, instead of being a compact size that's good for pumping, it's going to become waterlogged with the excess fluids, causing heart failure being not being able to contract very effectively. And then you could end up with arrhythmias, which are irregular heartbeats. Then in your GI tract, you could have anorexia, which is a loss of appetite. You could have nausea and vomiting because of the excess waste products that are floating around your body. You could have gastrointestinal bleeding because it can impact your liver and make it not produce as much clotting factors potentially. And then you could also have ulcers in the stomach or in the GI tract as a result of too much waste products. In the reproductive system, you may see sexual dysfunction as well as infertility as a result of having chronic kidney disease, because your body can't allow for the growth of a fetus if you're not in a healthy state. In the musculoskeletal system, your bones are going to be more likely to fracture because we said earlier that the presence of phosphorus in the blood tells the body to break the bones down for more calcium in order to bind the calcium, the phosphorus together. And so the patient who has long-term chronic kidney disease is more likely to experience some sort of fracture. Then neurologically, you could have fatigue, depression, headache, confusion, seizures, and coma, because again, you have way too much waste products, and these nitrogen-based waste products can get into the head and impair brain function. In the respiratory system, a lot of what we're going to see is respiratory or pulmonary edema, as well as accumulation of fluids in the lung space, known as pulmonary effusion. And then we could also have dyspnea, in which we have irregular breathing patterns. And the kidneys, we're obviously going to have anemia as well as low urine production. Some patients at end-stage kidney disease will produce no urine whatsoever. And so that would be known as anuria, in which you don't produce any urine. Then in the skin, we could have pruritus, which is itching. Pruritus is the medical term for itching. We could have ecchymosis, which is where there's bruising. And then we could have the uremic frost, which I showed you guys what that picture looks like. It's when we try to push the uric acid as well as other waste products out of the skin in order to get rid of it. Then that could result in dry skin as well as a yellowish hue to the skin. And then in terms of fluid volume, we're going to have edema. The therapeutic interventions for chronic kidney disease is that we want them to maybe potentially manage through diet. Having a high calorie diet is actually helpful for somebody with chronic kidney disease because your body is so sluggish due to the accumulation of waste products that having high calories helps your body power through some of those waste products that are in the way. We want them to generally be on a low protein diet because we don't want them to lose more protein unless they're on dialysis, which dialysis helps remove excess fluids and as well as waste products from the bloodstream. So if they're on dialysis, then it would be okay for them to eat a regular protein or even a high protein diet. We also want them to be on a low sodium, potassium, and phosphorus diet because we said earlier that phosphorus can bind with calcium, which weakens the bones. And then they could have hyperkalemia and hypernatremia as a result of having chronic kidney disease because their body is not getting rid of the excess potassium and sodium. So we need them to keep their diet a little bit low on some of these things so that it doesn't become overtaxing for your body. We want to increase calcium to offset the phosphorus in the foods that we may end up eating. We also want to encourage them to take vitamins because remember, the kidneys activate vitamin D. So if your kidneys are in chronic kidney disease, you need an active form of vitamin D in order to make sure that your bones are not losing so much calcium that they can't be replaced. And then we definitely need to put them on some sort of fluid restriction in order to make sure that they don't carry excess fluids, which would be, again, overworking the body. Other therapeutic interventions could be medications such as diuretics. Now, this only works, diuretics only works for the patient if they can still produce urine. But we said earlier that patients with end-stage kidney disease generally cannot produce urine anymore. They will have anuria. So then in that case, diuretics actually wouldn't help. We want to give them antihypertensives because we want to keep their blood pressure low because they accumulate so much fluids and they're not able to get rid of the extra fluids through the urinary tract. A antihypertensive can still help with the blood pressure to keep it low. We give them phosphate binders as well. Phosphate binders are really interesting because they're these huge white and blue capsules that the patient has to eat a couple of bites of food and then take a phosphate binder, and then eat another couple of bites of food and then take another phosphate binder. What phosphate binders will do is that they will bind to the extra phosphorus in the food as well as in the bloodstream, and then it will pull all of these phosphorus into the GI tract for excretion through bowel movements. So because you can't pee it out doesn't mean that we can't get rid of the excess phosphorus. And so phosphates will bind to phosphorus in order to allow phosphorus to enter the GI tract to be excreted as bowel movement in order to get rid of the excess. We also want the patient to take some sort of vitamin D and calcium supplement to keep their bones strong and healthy and prevent the risk of fractures. We also reduce potassium as needed. So these are some of the things that can help with removing excess potassium in the blood, such as a medication known as calcium gluconate. We could also give them insulin and glucose because remember the way that insulin allows potassium to be absorbed better in the body is that insulin is a key that opens the cells up in order to do more active transport and get certain things across their cellular membrane. And so when you open up the cells using insulin, potassium will end up going into the cells as well. And then you can give a medication called Kayexalate, which is a medication that binds with the excess ammonia in the body in order to allow it to exit the body as stool. And then we can also give a medication called Cartiromer, known as Veltassa, which is an oral medication. I actually cannot remember what Veltassa does, so I'm going to look it up right now. And it's a medication for hyperkalemia. So it binds with excess potassium in order for you to get rid of it safely through stool, again, instead of through urine. Okay. Kyaxylate is also, I'm sorry, I said earlier that it's a nitrogen binder. I had to look this up just now. It's actually a potassium binder also for hyperkalemia treatment. That was my bad. I'm, again, really tired making these. This is 90 something slides. It's a lot. And then the last thing to do is dialysis, in which we treat for symptoms of fluid overload as well as high potassium. And for some of these patients, they could have neurological dysfunction or signs and symptoms of confusion. And again, it's because there's too much waste products accumulating in the blood. Some of that waste product is ending up in the brain and impeding the brain function. And then we're going to have uremia, in which we have urine in the blood. It is as unpleasant as it sounds. And that is because, nobody's blood should have uric acid or urea in their blood that much. But at some point, this fluid has to go somewhere. And a lot of times they end up back into the circulatory system, carrying all the waste products that it normally would carry. That normally would be excreted through urine. Now, the cue recognition that you have is that you're reviewing the following laboratory results of a patient admitted to the unit with renal disease. Their calcium level is 9.5. Their potassium level is 7.0, which you should remember from exam. That's exam 1. That's extremely high. Magnesium level is 2.0 and BUN is 18. So if I'm not mistaken, I think the calcium and the magnesium levels are actually within normal range. It's the potassium that's super elevated. And so we need to give some sort of medication to bring down the potassium. And I think the BUN is actually within normal range as well. So we immediately notify the healthcare provider because their potassium level is 7.0, which is extremely high. They're at risk for dying from a heart condition at that point because potassium is used to regulate heart rate. Now, there are ways to treat chronic kidney disease. Earlier, I mentioned hemodialysis, which is also just known as dialysis. That's usually what most people mean when they say dialysis. So whether or not the hemo is in the front is doesn't really matter because most people know it as dialysis, but hemo specifically means blood. So in hemodialysis, we take blood out of the patient's body, circulate it through a filter machine, and then put the clean blood back into the body through another needle. So hemodialysis is artificial kidneys that remove waste products and excess water from blood through a filtration system. You need to have vascular access, meaning you have to have access to their bloodstream, and it has to be a really large, blood flow. Now, the vascular access can be temporary, in which you have a central venous catheter as a way to access the blood and perform hemodialysis. The other way you could do it is through something that is more permanent, such as an AV fistula. AV fistula stands for arterial venous fistula, or you can have a vascular access graft. And for you to understand this, I have to draw more pictures. So in order to create a fistula, earlier we said that a fistula is when two tubes are connected together when they're not supposed to be. In an arterial venous fistula, we connect an artery to a vein. So here's what happens. Here's my arm, my hand. And in my arm, I have arteries that supply blood to the hands. And then at some point, these arteries kind of turn back and then become the veins, right? So maybe somewhere at this point, this becomes the veins and circulates blood back into the heart. So the arteries and the veins eventually will kind of merge, but they're not supposed to be otherwise connected at all. However, in hemodialysis, when we create an arterial venous fistula, what we're doing is we're literally taking a section of the artery and connecting it into the vein. And so in doing so, what is actually happening is that this connection between the artery and the vein is where we want things to be. Because the arteries have a pulse to them, they have high pressure. Veins typically don't have high pressure, but if the veins were exposed to higher pressure, the walls of the vein will actually thicken as a result of it. So the part of the vein that touches the artery will thicken, and so will some of the veins in the natural vein part. It will also thicken. By thickening, I mean that the walls of the veins will actually become stronger and therefore more capable to handle cannulation. Remember that cannulation means the insertion of a needle. In order to do hemodialysis, you actually need two needles to access the blood. You need one needle that is within the artery, and then you need another needle that is within the thickened part of the vein. You need it to be thick because the needles that are used for hemodialysis are huge. They're 18 gauge. At 18 gauge, you can look through one end of the needle and see the other side. And that's the smallest needle used for dialysis. Usually, the patient will be on 16 gauge or 14 gauge needles. I knew one patient who even used a 12 gauge needle for his hemodialysis. And so, because we're accessing the blood supply so much, and we're cannulating with two needles every time they come to dialysis. So, if it was a regular vein and we were putting these large gauge needles into regular veins, those veins will blow very, very fast, meaning the veins will collapse and die off, and we won't be able to use it anymore. So what we need to do is we need to strengthen the veins in order to make sure that it can withstand repeated cannulations as they do dialysis. You always need two needles in dialysis because one needle is going to receive blood, and then these needles are connected to the machine outside of the body. And so one needle collects blood to filter through the machine. I'm not going to draw a machine. But then after it's been cycled through the machine and cleaned, then it's connected to the other needle through a tube in order to return blood back into the veins. And so that's what an arterial venous fistula is. It's when we connect the artery to the vein in order to strengthen the vein. But in order to do so, we need to make a connection between the artery and the vein. And remember, a fistula connects two tubes together or two spaces in the body together. Then you can have a vascular access graft in which you have, instead of strengthening your veins, maybe for whatever reason, your veins are not a good candidate for it. So then we put in a artificial graft between the vein and the artery. And then we take our blood supply from this graft instead. Okay, so still the same concept as a arteriovenous fistula. However, the vascular access graft is an artificial tissue in the body. And so over time, it becomes very prone to being clotted because the body recognizes this graft as being artificial and therefore doesn't belong. So this is what a picture of hemodialysis looks like. You can see that there's two needles in the patient's arm, and that it's getting filtered through a machine, through a dialyzer, in order to filter out excess waste products as well as excess fluids. So this is another picture of a patient undergoing hemodialysis. This is a really old picture. These machines don't look like this anymore. So with hemodialysis, it's really important to establish a permanent vascular access and as well as to take care of that vascular access. If the patient has a fistula or graft creation, you cannot take blood pressure or labs by drawing blood from that arm because we need to save the access of that arm for hemodialysis. So we're going to care for them postoperatively for after their fistula or graft surgery. We're going to give them neurovascular checks and monitor them for pain. We're going to elevate the extremities because they're probably going to have some sort of swelling after surgery. We're going to verify the thrill and bruit patency of this axis. So the thrill is of the fistula is actually a noise you can hear with that fistula. And so thrill and I'm trying to think of the best way to explain it. A thrill is a vibration and a bruit is a sound that indicates good blood flow in a fistula. So a lot of times when the patient has a fistula, one of the assessments you'll do is you'll put on your stethoscopes and you'll put the stethoscope up to the fistula. You don't have to press down, you can just put it over the fistula, and what you'll hear is a whoosh, 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 whoosh noise. That whoosh, whoosh, noise means that there's an adequate amount of blood flow from the artery into the vein in this fistula. If you don't hear the whoosh, 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 thrill noise of the fistula or that particular graft, it means that there's not enough blood flow to that part of the body, and therefore you cannot use it as a hemodialysis access site. Bruit is I'm sorry, thrill is a vibration, bruit is the sound. So the whoosh, whoosh, whoosh is bruit. Thrill is the vibration where if you put your fingertips onto the fistula, you're going to feel a very hard, very hard pulse. And it's going to be very obvious. And sometimes you don't even need to put your hand on the AV fistula to be able to see it. Sometimes you can see the AV fistula pulsating. And so the pulsating or the vibration is known as thrill of the AV fistula, but the bruit is what makes that whoosh, 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 whoosh noise. And that noise means that there's a lot of blood supply flowing through that area at the same time. Both thrill and bruit has to be present in order for you to use the fistula for hemodialysis. If one or the other or both is absent, it means that you cannot use this fistula access for hemodialysis anymore because it's no longer functional. We want to protect the access. So again, no blood pressure or blood draws in the arm with the AV fistula or graft creation. And also, a lot of these dialysis machines have a way for you to draw blood from the system instead of drawing blood from the fistula access directly. So we can draw their blood really easily when we are doing their hemodialysis because the machine allows you to attach a syringe to it, to certain chambers in the machine, in order to just draw a little bit of blood for the purpose of labs. We're also going to educate the patient on how to care for their AV fistulas. And we also need to emphasize the importance of going to hemodialysis because again, if they don't, they will die and it will be a very unpleasant death and it will be an agonizing death, meaning it lasts several days before you finally die of drowning in your own fluids from being fluid overloaded and also by having uremia, which is urine and blood. So these are some of the access for fistulas. In picture A, you have a fistula in which we literally sew an artery and a vein together. The part where the artery and the vein connect is called anastomosis, in which it just means a combination of the two. And then in the second picture, you see a graft in which there is an artificial tube that is put in that connects the artery and the vein together. Another form of dialysis is known as peritoneal dialysis. Peritoneal dialysis means that we're using the lining in your abdomen to dialyze, meaning to remove extra fluids and waste products from the blood. This is a continuous dialysis performed by the patient. A lot of times they can do this at home. The peritoneal membrane, which is a lining in your perineum, you have a lot of it in your abdomen because you have so many organs in your abdomen. You have a bunch of linings to hold those organs together in place. So these lining are known as peritoneal membrane, and they're semi-permeable, meaning that you can filter some things through. And so if we push water and fluids across this membrane, we can get some of that excess water and waste products out by using the membrane as a filter. In order to do peritoneal dialysis, you would have to have a peritoneal catheter inserted into your abdomen, and in which there's an exchange process where the patient has to fill their abdomen with a certain amount of dialysate first. Dialysate meaning it's a fluid that we use to wash out the excess toxins and other waste products from the membrane. Then we let it sit. We let that dialysate sit inside of the body for a certain number of hours. I don't remember how much you need to do for it, but it's usually a couple of hours. And then after those couple of hours, you can attach the peritoneal catheter to a drain bag in order to let the dialysate drain out. So here's a picture of what it looks like to do peritoneal dialysis, in which you have a peritoneal catheter. And so we connect a bag of fluids to this catheter and allow this fluid to get inside of the space between the muscles of your abdomen and the organs of your abdomen, because that's where all the linings are. Once it's done, what you'll then do, or once the fluids come inside of the body, we're actually going to detach the peritoneal catheter, let it sit inside of the body for a couple of hours, and then we would drain it out by connecting the catheter to another bag, and then just letting it flow out by gravity. So these are two forms of dialysis. You just need to know how they're performed. But on the exam, we're going to focus more on hemodialysis rather than peritoneal dialysis. Now, dialysis is a way to treat chronic kidney disease because you can't filter the toxin out on your own anymore. But obviously, that's not the only way to filter out toxins or waste products. Another option is a kidney transplant, in which we get a healthy kidney from somebody else and implant it into the person. So this is generally a living related donor or a cadaver donor. So living related donor means that it's maybe a sibling or a cousin who has compatible blood and kidney to you, that they donate one of their healthy kidneys to you. Cadaver donor means that they might have died in a car accident and they're an organ donor, and they have given permission ahead of time to harvest their organs. And so a cadaver can also, or somebody who's passed, can also donate a healthy kidney. In order to be on a transplant, you have to be on anti-rejection drugs for the rest of your life. Anti-rejection drugs are also known as immunosuppressants. We have to be on an immunosuppressant for patients with transplants because your body is full of cells that knows that it's supposed to be in there. The DNA in our nucleus tells us these cells belong to Helen and helps my body identify when cells or organs might not belong to Helen. And so immunosuppressants suppresses our immune system from recognizing that a donated organ is not my original organ. And so it kind of helps me suppress my immune system from going to attack this donated organ. But as you know, with immunosuppressants, you will have a harder time fighting off infections because you can't rely on your immune system to produce antibodies. So this is a picture of somebody who might have gotten a donated kidney, in which you can see you don't get a kidney donation unless both of your kidneys have failed. That's because your kidneys are both functioning at 100% at a time. And when one kidney fails, as long as the other remains at 100%, then you're fine because you can live on one kidney. However, with chronic kidney disease, there's generally disease in both kidneys, not just one. And so when that happens, we can take a transplant kidney and then attach it to the patient's body. Just as this photo shows, when you get a kidney transplant, you actually do not get the diseased kidneys removed. The reason for that is because these diseased kidneys, it would be a huge hassle to actually remove that. So if they're not causing disease in your body, they're just kind of useless. We kind of just let them hang out in the body. Because as you can see, the kidneys are attached to huge arteries and veins. So if you want to remove the kidney, even though it's diseased, a lot of times what will happen is that the patient may bleed out a lot because the kidneys are connected to a huge amount of blood supply. And so instead of removing the kidneys, which is way too much of a hassle than a benefit, we just attach the new kidney to the patient's body. And then we make sure that there's a ureter that's also transplanted in order to make sure that the kidney receives blood supply from the arteries and the veins, but also there's a drainage tube or one ureter to drain to the bladder in order to ensure one-way passage of these things, of the waste products. So in chronic kidney disease, you're going to have excess fluid volume, impaired skin integrity, decreased activity tolerance, risk for injury, risk for infection, imbalanced nutrition, and lessened body requirements, because these are all part of what happens. We talked about how you're going to retain fluids because you're not going to pee it out. You're going to have uremic frost, in which we try to get rid of some of those waste products through the skin, which causes skin dryness. There's decreased activity tolerance because you're going to be fluid overloaded. You're going to have fluids in your lungs. You're going to feel bloated and therefore difficult to move around. You may have risk for injury because you could be more at risk for fractures because phosphorus can bind with calcium, which calcium comes from bones. And so the more phosphorus there is, the more we break down our bones to bind calcium with phosphorus. You could be at risk for infection because when your body has chronic kidney disease, it's too busy managing the chronic kidney disease to care about the immune system. Plus, with so much waste product just floating around in your body, that impedes the function of some of your other systems, including the immunosystem, the immune system. And then there could be imbalanced nutrition because there could be, we're eating too much foods with phosphorus, sodium, or potassium. And so this could be impacting the amount of waste products we have in our body and also make it harder. There was that picture of what happens to the body when there is chronic kidney disease. And there was even a section that's about how GI tract, you can have more gastric bleeding or GI tract ulcers as a result of having chronic kidney disease. And it's generally because you can't absorb nutrients as well. For excess fluid volume, we're going to monitor weight, intake and output, restrict fluids, and then monitor for fluid retention. For electrolyte imbalances, we're going to monitor their levels and restrict diets so that we limit the potassium and sodium that they receive. And then we're going to monitor for arrhythmias because if their potassium is too high, that could cause a irregular heart rate. We're going to monitor their waste products and we're going to perform good oral care and skincare in order to make sure that we don't provide excess pathways or portals for pathogens to enter. We're also going to lotion or moisturize the skin to prevent tears because, again, tears in the skin can lead to a portal for pathogens to enter. And we want to protect them from injury because they have an increased risk for infections. Then we're just going to monitor for impaired hematological function and again, protect the patient from injury or infection. This this is a case study with a concept map, which I'm not a huge fan of that. So I'm just going to skip those and go right to the review questions. This review question says that the nurse is collecting data on a patient who has presented to the healthcare provider's office with a fever. Which of these followings are indicators of a UTI? So UTI, we can have urgency and frequency for sure. And we could have concentrated urine, but we're not going to have ammonia smelling urine. So 5 is out. But right now I'm at least sold on 2, 3, and 4. And I remember that with UTI, it's actually not dysuria, it's burning that you feel. So with UTI, the signs and symptoms are urgency, frequency, burning, foul smelling urine, cloudiness, and pelvic pain. So I don't dysuria is one of them, but I could be wrong. Okay, I was wrong. It is 1, 2, and 3. It's dysuria, urgency, and frequency. And I guess with amber urine, it's actually the concentration of the urine doesn't actually impact the chances of developing a UTI or the presence of a current UTI. So that's fair. The next question says, which actions are essential for the nurse to take when providing care to a patient with renal calculi? Renal calculi, again, being kidney stones. So select all that apply. One, we're not going to limit fluids because we need more fluids in order to thin out the urine to prevent the urinary salts from crystallizing. We're going to strain all urine because we want to see when they pass the stone. So we're definitely going to do that. We don't necessarily need to maintain bed rest unless their stones are extremely large, which at this time we don't necessarily know that. So I don't think we need to maintain bed rest. We're going to restrict dairy product because dairy product is full of protein and calcium, which at this time we don't want the patient to have more of. And so because calcium and protein can contribute to the formation of stones, so we're not going to do 4, or we will do 4 actually. And then we want to provide pain relief because passing kidney stones can be very painful. So yes, we're going to do that. And then yes, we're also going to maintain IV hydration because again, we want there to be more hydration in order to prevent these stones from forming or enlarging. So we're going to do 2, 4, 5, and 6 is my guesses. I don't think we do 3. Oh, okay. 2, 5, and 6. So no 4. So I guess you don't need to limit dairy product. Okay. Now, this question says, which of these actions should the nurse include in a teaching plan to help prevent or slow the progression of diabetic nephropathy? Select all that apply. In this one, diabetic, it's definitely going to be control blood glucose. Control blood pressure. A lot of times if you have diabetic nephropathy, you have poor glucose control, you also may have blood pressure issues. So I think we're going to do 1 and 2. We're not going to, I don't think, well, no, actually we do need to limit the fluids because in diabetic nephropathy, they're not able to excrete as much fluids. So we have to restrict that. And then I think we do have to restrict protein in the diet. And then, but I don't think we need to increase the insulin dose. So I believe for this one, it's 1, 2, 3, and 4, but I could be wrong. So it's everything but 3. We're not going to limit fluids for the patient with diabetic nephropathy, which is fine. It's just something that, hey, even I have to review too, right? So if I, who have like years of experience, in fact, I was a dialysis nurse for 2.5 years. So with this chapter, I'm relatively comfortable, but even I can't remember everything when it comes to the kidney diseases. So you as a student, you need to buckle down and really study some of these questions and some of these slides, because if you don't, or you're not reading the textbook, you're missing out on a lot of information. Next question says, while the nurse is caring for a patient, what is the priority action to prevent acute kidney injury? And so we could check GFR and creatinine prior to contrast media or nephrotoxic medication, which I believe that is it, right? Because that is contrast-induced acute kidney injury. 2 says read protocols to prevent contrast-induced nephropathy. Okay, that is also a good idea. But we want the priority action. So maybe let's read through all the options. We want the patient to hydrate before and after the contrast media, and we want to monitor nephrotoxic drug trough levels. Out of all of these, there's a certain order to do these, and I believe the order is actually in what is outlined. And so, yeah, I'm just going to go with 1 where we check the GFR and creatinine for clearance before we even introduce the contrast or give nephrotoxic medications. So that one was correct, thank goodness. And then this one says an 85-year-old patient who has fallen at home and was unable to get up is admitted to your nursing unit. The patient says she fell 36 hours ago and has been unable to eat or drink. You observe that the patient has voided scant amounts since admission. In planning care for this patient, what condition do you consider related to the diminished renal output? So this patient has fallen at home, unable to get up, 36 hours ago and has not been eating or drinking. And the patient has voided very small amounts, so that's oliguria. And then what could be causing this diminished renal output? So inactivity and nephrotoxic drugs is generally not going to impact renal output. So I believe it has to do with either hypovolemia and renal calculi. This chapter is, we talked about renal calculi. We didn't really focus on hypovolemia, but if I'm being fully honest with you, when a patient falls at home and it's been several hours, a lot of times they're not, there may be bleeding internally that we're not aware of. And plus with the oliguria, renal calculi can certainly cause oliguria, but if there is a blockage, but the patient also is not complaining of severe pain. And so this is very unusual. I'm going to say hypovolemia, but I have a feeling it might be renal calculi. Oh, but it is hypovolemia. Thank goodness. I can hold on to my nursing license for another day. And that is it. So very, very long chapter. It is kind of difficult. Even I have trouble with it. So you as students definitely need to study. This is a tough chapter. It does not necessarily mean that there will be more questions about the kidneys than the other chapters, but it is a lot of information to remember. So do whatever you can to help you remember what was discussed in this chapter, and I'll see you in class.